Good morning to the audience. Thank you, Gauri. And I would like to first introduce the two panelists. Dr. Muruganathan is a well-known figure. He is an expert physician with a special interest in hypertension. And he's a very senior physician, a godfather-like figure for all of us. Welcome, sir, for this session. And we have Dr. Anuj Maheshwari from Lucknow. He comes over every year to Chennai. Welcome to Chennai, Anuj. So, and Dr. J.S. Kumar, who is a professor of medicine, will join us very shortly. Before that, we will start. What are the objectives of this session today? It apparently looks very simple. You know, when you say hypertension, oh, it is only hypertension. It's not a big deal, or it is easy to manage, start some drugs, etc. But control of hypertension has got a lot of benefits, a lot of public health benefits. It brings down mortality, it brings down morbidity. So a simple thing like hypertension control, which can be done by anybody, by a general practitioner, a physician, any specialist for that matter, even take a surgeon as well. A simple control of hypertension will have long-term benefits to the patient. So with that small introduction, these are the objectives of today's session. We are going to talk about a group of patients in whom hypertension is very difficult to control. That's a definition for it. We will go through the definition later. And what are the strategies and targets in a patient with difficult to control hypertension based on age or comorbidities? Many of them have comorbidities with them. The third objective is how will you identify and investigate patients with secondary hypertension? There are a subset of patients who are classified as secondary hypertension. And how will you test for those secondary causes? Any role for third or fourth agents which you may have to start on these patients, and identify some patients for expert opinion. I hope I am clear with my objectives. Anytime during the session, you want to stop and ask questions, you want to add your opinions, you can do so. This is an interactive session. So it is a clinical case presentation session. So you can ask your doubts. You can ask for any clarifications during the presentation. The panelists will be more than glad to answer that. And they will also add their points as we goes by. Can we start, sir? Dr. Muruganathan can also give his overview before we start so that the other panelists will join. You want to add something, please?
Thank you very much. Good morning. Good morning.
Good morning, sir.
Yeah, very nice. My friend, Dr. Damodaran, my brother, Anuj, is also the current governor of American College of Physicians, and he was the vice president of RSSDA. So his interest is more for diabetes. Now I tracked him to hypertension also. So now I made him diabetes and hypertension together. So I'm happy. I thank the organizers for introducing hypertension in the debate. Because all the time, we talk about hypertension, diabetes only. I am a person who is a proponent of, focusing on hypertension. In India, there are more than 21 crores of people with hypertension. And nearly 20 crores of people are in the borderline, pre-hypertension. So the hypertension is 3 times more prevalent. The morbidity and mortality is more than 3 times compared to diabetes. But unfortunately, we don't have many people who are taking interest in hypertension like me or Anuj. So I want, first of all, first message, focus on hypertension, concentrate on hypertension, and then promote home blood pressure monitoring. We always promote home blood sugar monitoring, but we don't promote home blood pressure monitoring. So hypertension is now, even in younger age, if you see people below 40 years, 1 in 8 have hypertension. And they are not under control because they don't pay attention, they don't take treatment. Late diagnosis and then non-compliance in young people. And then again, women and hypertension. Pregnancy hypertension is a big problem. We have pregnancy diabetes, a big forum. Anuj is one of the specialists. Is going to Lisbon to address pregnancy diabetes. But we don't have any pregnancy hypertension. So like that, hypertension is a poor cousin of diabetes. So first of all of you, please understand hypertension should be the focus. I'm glad Krishna Seshadri has given about the importance of hypertension here in this debate. Coming to the difficult to treat hypertension is a broad term. Even we have different definition. One is called uncontrolled hypertension. What is uncontrolled hypertension? If you give a patient 2 drugs, the BP is not under control, I welcome Kumar. Please, Kumar. If you give two drugs, if there is no control, this is called uncontrolled hypertension. What is resistant hypertension? You give three drugs, out of which one is diuretic. You give all the three drugs optimized dose. So that is resistant hypertension. This we call it as apparent resistant hypertension. Why we call apparent hypertension? You have to rule out pseudo resistance. See, in many patients, they will have resistant hypertension because of pseudo resistance. The pseudo resistance is again, it may be doctor related or patient related or drug related. So patient related means non-adherence. Doctor related means inertia. Drug related means, you give too many drugs. Simplified protocols is not there, and improper dosing. So you have to rule pseudo resistance, especially in elderly people. We do what is known as Osler's maneuver to rule out pseudo resistance. Okay, that is apparent resistant hypertension. Then there is a definition called control resistant hypertension. What is control resistant hypertension? You give 4 drugs, the blood pressure is under control. So resistant hypertension, when we give 4 drugs, if this control is called control resistant hypertension. And the 5th one category is called refractory hypertension. What is refractory hypertension? You give more than 5 drugs, still the hypertension is not controlled. There only we do, apart from drugs, we also do devices, mechanical intervention. So these are the overall, think about difficult to treat hypertension. And as I told you, many pseudo resistance also the cause, because the many doctors, when the patients come, if the patient has got 148 and 92, they say, okay, we'll see next time. So clinician inertia and lack of adherence also is one of the things. Then proper follow-up. We don't follow up regularly like what we do in diabetes. So these are all the things which, one should have. These are the drive home messages for hypertension, introductory message. Now over to you, Damodar.
Dr. JSK, sir, thanks for coming. And what is your thought on this target of 140/90? Do you think it is 140/90 or 130/80? This also keeps changing all the time. So what is your view on this?
See, various societies, international societies have their own guidelines. And if you're looking at the comorbid condition, that's very important. If you're looking whether the patient is having CKD, chronic kidney disease, or patient is having diabetes. And also we are looking at the proteinuria. So if you're looking at the latest guidelines, that is the KDIGO guidelines on CKD 2021, they have got the target as low as 120/80. Systolic should be 120. And that's based on one particular randomized controlled trial, which is called the sprint trial, and in which the diabetic population has been taken off. So it's been done on non-diabetic population. How we are going to extrapolate for diabetics, something that is still big a question mark. But what they have seen in that study is that there has been a good reduction in the relative risk reduction of almost to the tune of 30% on patients with good control of systolic. But we also should know that there is a J point, especially when we had in hot trial, but it was then you looked at the diastolic component. But definitely we'll have to be, the target should be individualized. And when there is proteinuria, we have to get the sugar, we have to get the blood pressure to 130/80 and below that. If patient I can tolerate, that's very, very important. So the numbers probably does not give you the whole picture. The patient has to tolerate. There should not be, patient should not have symptoms of giddiness. So we have to be very careful. And in diabetes, long-term autonomic issues are also going to be there. So orthostatic hypotension also plays in. So the drugs that we give, everything plays a major role.
In fact, I will add, there are a lot of international guidelines. It's confusing. Say American guidelines says 130/80, the European guidelines says 140/90, and the Indian guidelines says 140/90. Whatever the guidelines definition, the preferred threshold should be around 130/80, 130 systolic and 80 diastolic. If you can achieve nothing like that, as Kumar said, you individualize. If the patient can tolerate, if you can reduce to 120, if the patient can tolerate, nothing like that. We always go with biological age than chronological age, by which I mean, if somebody above 65 years, if they are active, independent, you can reduce up to 130. If the same individual 65 is frail, the BP should be 140. So depending on the age, biological age only, we do that. Same way, somebody who's got 70, if they are very active, you can still reduce to 130. If somebody is 60, not active, then you have to have 140. So it is a biological age rather than chronological age. Individualize the target, and best target should be 130, 80 around, because we don't need to lower down because of the problem of J curve, etc.
Dr. Anuj, you want to add?
It is always said that lower is the better. If you are keeping your blood pressure on the lower side, you are always on the safer side. All the accidents and all the emergencies arises when blood pressure rises. But still in our country, there is a trend, people don't want to keep their blood pressure on the lower side. Very rarely we have seen that symptoms arises on the lower side, but still we don't want to keep, and many times it has been seen people, once the blood pressure comes down to nearby 120, 80 or even lesser than 120, 80, many people stop the medication. Sometimes doctor also don't care of this thing once the people stop the medication. So this thing should always be kept in mind if we are doing that. Lower is the better, especially in India, because India is a country which is having a lot of metabolic potential. We are the second to the in the world for the diabetes, and a lot of metabolic and adiposity and visceral adiposity is there in our country. So if we shall be following less than 130, 80, or in kidney patients or those who are having the renal disease, less than 120 would be safer for us. But in diabetes patient, there are some studies which does not allow to go lesser than 120, because there are again certain complications may arise, and because already a vascular complications and compromise are there in the diabetes patient.
One more extreme about hypertension. In elderly person, when you give drugs, always look for orthostatic hypotension, because that is also in one of the caveats, because you give the drug and the patient falls. It's a big problem for elderly patients. So orthostatic hypotension, we define, you check the blood pressure after the patient standing for 3 minutes, and if there is fall more than 20, it's orthostatic hypotension. So orthostatic hypotension also you must keep in mind. When Anuj says about diabetes, there is another entity called postprandial hypotension. So that also you must think in, especially diabetes and elderly person.
Yes, please add.
Just to complete the discussion, I think we have been doing only the office. I mean, I think the new guidelines, KDIGO especially has given how to do in blood pressure monitoring. That's itself, they have there are a couple of pages on how to check the blood pressure. Patient should come in, should have emptied his bladder, should not have taken any caffeinated beverages. He should be seated, and you should have a validated blood pressure monitoring. All this comes under in office BP. So the BP monitoring itself, you can produce a lot of issues. So these numbers per se all depends upon, at least we should take 3 readings, and you have to take the average of the second and third. If you can do that, probably we'll get a number as accurate as possible. The first BP, when you are taking in a validated blood pressure, especially the validated one also, it will always show on the higher side. So that's very important thing. Just imagine how many of patients are going to do the same thing in a hospital, in office sitting. Very, very difficult. They come, they are already in stress. They are in a calm mental, frame of mind. So these always the BP will be on the higher side. That's the reason that we are going towards the ambulatory blood pressure monitoring and home BP recording. As we do self-monitoring of blood glucose, I think we should also advise every hypertensive patient to have a BP apparatus at home, so that he can bring the record, logbook of his blood pressure recording. Especially you have to look at the nocturnal dip. So I think there are a lot of, itself is a, entity, or whether how much is the nocturnal dip, there are dippers or non-dippers. So ambulatory blood pressure monitoring, I think has to be, now it is available, and we have to use it to its fullest potential.
I agree with Kumar. Every one of us must teach the patient, the paramedicals and nurses, how to measure blood pressure accurately. There is a statistics they say less than 3% of the people only are measured accurately. So we have to give more importance to accurate blood pressure measurement. All the guidelines, not only KidGo, even American Heart Association, European Heart Association gives 5 pages how to measure blood pressure accurately.
Thank you, sir. So we'll agree on 130/80 as a target blood pressure in every patient. So this slide shows the etiology of hypertension. Anuj, any comment on this? It says that 95% are
Yes.
primary or idiopathic.
Secondary hypertension requires a big battery of the investigation. But that kind of the battery is not really required for the workup of every hypertensive patient, because 95% patients are the primary hypertension, and they can very easily be managed. But it is very much important how to identify the secondary hypertension if it is there. And it's really very difficult, and without the help of the investigation, it is not at all possible. But whenever we see the hypertension in less than 40 years people, we must test or we must investigate for the secondary hypertension, because then there are the chances are very high. Even if it is coming to a less than 20 years, many of the people are having this. In India, I would like to add one thing, that Indian peoples are having sympathetic nervous system overdrive also. And that is very important reason for hypertension in India. So, and of course, the cost factor is very much important whenever we ask the patient to go for the battery of the investigation for secondary hypertension. So there is a very thin line between these two. We must ensure that whether the person is not having the sympathetic overdrive, and if it is not there, and if it is satisfied and still the patient is having the hypertension, better we should go for the battery of the investigation, which is required for diagnosis of the secondary hypertension.
Thank
Yeah,
you,
in
sir.
fact, I would like to make an emphasis. Still, clinical examination and clinical history is very important. Clinical history and clinical examination is the forgotten art. So now there are so many battery tests have come, but still clinical examination is important. The suspicion when somebody has got hypertension, as Anuj said, extreme age, below 20 years or above 50 years, sudden BP, and if they have no family history and they have the symptoms, suggestive of pheochromocytoma like palpitation, pallor, or pain, or Cushing syndrome, signs, some symptoms, then you will have to look for other symptoms and then do the battery of tests. Otherwise, even the suspicion, clinical examination itself. So you'll have to examine head to foot. Coarctation you will miss if you don't examine the lower limb pulse. So you should be very clear. If you don't look at the thyroid, and you may miss thyroid hypertension. Hypothyroidism or hyperthyroidism also can cause hypertension. And they say hypothyroidism more of a diastolic hypertension, hyperthyroidism more of a systolic hypertension. So you'll have to have clinical examination, and clinical history is important apart from the battery of tests.
Thank you, sir. I think it's a good practice for us.
Dr. Damodaran, here I would like to
Please.
mention one thing for the secondary hypertension. Many a times we see that a student, those who are entering in the medical college, on the first day when they go for their health checkup, they found hypertensive. But actually this hypertension is not a secondary hypertension. We should not think that this could be a secondary hypertension. This simply because of the sympathetic overdrive, there is stress level, there might be over anxiety. So these factors should always be taken care. Oral contraceptive, you have mentioned very rightly. Nowadays, this is a very important reason of getting the hypertension in youngsters. So whenever a person is coming, or especially a female is coming with hypertension, we must ask her that whether she's using the oral contraceptive or not.
And decongestant, and the vitamin ginseng. So those drugs also can cause hypertension. So when you ask the history, ask them whether they are using decongestant, whether they are taking ginseng, NSAID. So these drug history, interfering substances also can cause hypertension, especially resistant hypertension. Unless you get the history, it's always a problem. If somebody is taking NSAID, you must also choose the drug antihypertensive accordingly. Then only the hypertension will be controlled. NSAID patients without amlodipine or calcium channel blocker, that control may not be good. So you'll have to choose the drug. If they're salt sensitive, that also you have to find out and then choose the drug accordingly.
Thank you, sir. So this is, any comments on this slide? This is the percentage of patients who had resistant hypertension from an Italian study. And it says that 17.4% come under the category of resistant hypertension. But many studies have said that it is almost 30%. About on treated patients, if you take 100 patients whom you are treating with hypertension, 30 of them come under this category of resistant or difficult to treat hypertension. So how many in the audience think that you're using more than 3 drugs to control hypertension, or whether your patients are on resistant hypertension? You can raise hands. How many in the audience think that their patients have resistant hypertension? The definition being 3 drugs, including a diuretic. Nobody. So all of your patients are under control, 120, 130, 80, and that is a good practice. Sir? So only in the CKD subset you have a problem. Elderly patients, sir, there's no right or wrong answer, so you don't have to worry. Because I find many elderly patients whose blood pressure is very difficult to control, especially the systolic pressure. It's always high.
Yeah, I think elderly person and also when somebody comes, the first day itself, the first hypertension itself more than 180, 110. Those are the people who are going for a resistant hypertension. And women especially will go for a resistant hypertension. And patient with diabetes, they can go for a resistant hypertension. These are all specific causes apart from, I'm sorry, you have to look for them. Being a woman itself, you will be a potential candidate for resistant hypertension because of so many reasons of the women's hormones, pathology like that. So elderly person, as you rightly said that, and somebody comes first time you see more than 180, is the patient going to got resistant hypertension?
What the data you have presented, if we, this is the international data, Italian data. If you do this similar kind of the study in Indian population, probably the 10.4, which is coming of untreated hypertension, that would be the largest chunk in Indian population. Because many of the times Indian people don't treat their blood pressure despite knowing they are having hypertension. A lot of people may be undiagnosed, but people in India are having the tendency to go with high blood pressure. They don't prefer to treat it up to the desired level.
Exactly.
Yeah.
Sir.
In
Very
fact,
correct.
there are a lot of studies in India. Less than 14% only takes the medicine for 1 year. When you start the medicine, only 1 year they take 14% only. And then complaints with the drugs also. Suppose ARB is supposed to be better. All the other drugs, they stop even in 2 to 3 months. And especially younger people, they don't continue. Because the problem is hypertension is a silent killer. It is very difficult to convince a person. Correct. When they come and they say you have hypertension and I say I have no symptom. And till they develop target organ damage, they may not have symptom, and it's very difficult to convince them to take drugs for continuously because it is a lifelong treatment. And then even lifestyle modification also, they don't understand and they don't follow.
Correct. Thank you, sir, for the
For
inputs.
the interest
yes.
of postgraduates, I think a patient who comes to you for the first time and you see the blood pressure more than 130/80, he may come for any other reasons. I mean, which probably may not be related to probably headache, or he may have come for whatever may be the reason. Please make sure that you advise 2 tests, which of all the tests you do. You look for the EGFR and urine albumin. Only the issue is that when fever is there, you know that you have to do it in another setting, or patient has come after a physical activity or urinary infection or had a fever. Probably you have to do for another setting, but make sure that don't just go with creatinine, because creatinine absolutely has no value unless until more than 50% of the functioning nephrons are gone. So EGFR by CKD EPI formula has to be written somewhere in your OP card. That will sensitize the patient and make him understand more. This is also for him to motivate to take the medications. Sometimes they will say BP 113/80 is, 140/90 is okayish. But probably if he has proteinuria and albuminuria, I think we have to start treatment.
One drive home message for all of you: opportunity screening, very important. In India, the private sector is only looking after more than 70% of patients. And then they compare hospital, government, and then private. They find the opportunity screening for private people are less. So when somebody comes with little finger pain or abdominal pain, check the blood pressure, whether it's surgeon or a pediatrician or obstetrician, check the blood pressure. I go one step further. You check the pressure of the person also, for the attender also. Then only you get the opportunity screening. Otherwise you cannot get screening. Now I have given blood pressure apparatus in my Coimbatore airport, railway station, bus station, and shopping mall especially. All the husbands will have hypertension in the shopping mall. So you keep the blood pressure, home blood pressure monitoring in the shopping mall. So there you create opportunity screening so that we can identify more patients in hypertension so that we can control and treat.
We'll go with the case now. Mr. D is a 66-year-old, hypothyroid 12 years, diabetic 8 years. He comes to your clinic, and as you saw your profile on a website of a prestigious hospital, JSK, your case, he has also been diagnosed with hypertension for the past 4 years, but not being seeing anybody since 2019 due to a COVID scare. As you know, during COVID, many of them would not have visited a doctor, and this was the scenario. Complaints include breathlessness on exertion 1 month, puffiness of face, swelling of legs for the past 3 months, numbness in both the feet, 75 kgs weight, height 170, BMI 26. Can you analyze this case, Dr. JSK? What is your opinion on these presenting complaint? Then we'll go to the
Yeah, this was a
Clinical
patient who
insight.
actually, it's not a hypothetical case, the real patient of mine who had been coming to me, but unfortunately for past 3.5 years, he couldn't make a visit because his children did not allow him to go out because he was apparently keeping well. But you can see that he's been having diabetes for 8 years, as well as he had thyroid problem. And now he complains with probably with what postgraduates, if you are there, what is this now the presenting complaint look like? He has dyspnea on exertion, as well as he has swelling in the legs for last 3 months. Probably it could be nephropathy because puffiness of face is there. And number two, we should also look for whether he's also having cardiac failure. So two things should come in across your mind, whether he is going for an cardiorenal syndrome. It can be both. So, and he has, of course, being a diabetic, he has some issues regarding his microvascular complication, the form of diabetic retinopathy. And you can see that he is overweight.
Yes. And he has numbness in both
think
feet, probably. he has
66
got-
years of the age, arterial stiffness must be one of the important contributing factors. Apart from that, he is having so many risk factors. Obesity is also there. So all these things are jointly making a contribution in the difficult to treat hypertension in this patient.
So this is a very typical patient where he is not only elderly, 66 years, but he has also got, he's been a hypothyroid. He's a diabetic. Now he has presented with breathlessness. It could be due to either macrovascular or microvascular complications. Always rule out anemia in these patients because that could add or contribute to the breathlessness. And he has numbness in both the feet. Probably he has got peripheral neuropathy as well. So this is the examination. No pallor, bilateral pedal edema, JVP not raised. BP is 162/100. Fine basal crackles are there. Otherwise normal. He is on multiple medications. Can one of the panelists comment on the medication, sir? JSK, you want to take, or Anuj, anybody can take? He's on thyroxine,
What is your question, sir, please?
multiple medications in an elderly
Yeah,
patient.
multiple medication always remains a barrier for the compliance. And many of the time people don't follow the medication rightly at the right time. And that also makes it difficult to treat hypertension. What you very rightly said, pseudo hypertension. Actually, it is not difficult to treat hypertension if people are not taking the medication. That's why it is coming up as a always hypertension. So that kind of the things might be with this patient, but here we can say that fundus is showing the grade 2 hypertensive retinopathy. And this gives us a clue that there must be some nephropathy. Because whenever the grade 2 hypertensive retinopathy is there, the nephropathy is a very high chances of occurring there. And we can also see the neuropathy and other complications are coming up. ECG is showing the sinus bradycardia with left ventricular hypertrophy. And left ventricular hypertrophy is usually for the long-standing hypertension. Many a times people, those who are ignoring their hypertension, not taking appropriate treatment, they come with the left ventricular hypertrophy. So these are the things which gives the clue how to go with this patient.
One
Thank you, sir.
important message I want to give you. Nowadays, every guideline says start with combination therapy. So even if the first visit, you give combination therapy. You know, some of the international guidelines say somebody comes to you first time, BP is only 148 and systolic is 92. You start them with combination. For example, amlodipine 5 milligram, telmisartan 40 milligram, 1 tablet. First visit, you give off tablet, combination. So even the first visit, you start with combination. So combination therapy is the rule. So that's why when you see so many drugs are there, metoprolol, lisinopril, if you give combination therapy, it's good for patients' adherence and good also. So message is all the guidelines, even for diabetes, they say is combination therapy. So I think combination therapy, the message is combination therapy, even in the first stage itself.
Thank you, sir. And it's always a good practice to get the fundus examined in these patients. Unfortunately, today fundus exam is a dying art among physicians. So I think at least we should get an ophthalmologist examine the fundus and get a picture of the fundus and get a report on that. Monofilament testing is enough to rule out peripheral neuropathy. And
Much
this is
easier.
Showing
Sir,
LVH.
just to interrupt you, sorry. Much easier is to go for the heuristics for the albuminuria.
Yeah,
Because
that is also.
that is also very important information to give us that if a patient is having that apropathy.
Yes. Sir. And ECG shows LVH. Probably the criteria for LVH was there. It may also be good thing to get an echo done to measure the wall thickness and see if there is, enough damage done in the heart. These are the investigations. Hemoglobin 10.5. Fasting postprandial well controlled, reasonably controlled for a 66-year-old man. Creatinine is 1.7, EGFR is 44. Any comments on this? JSK, you want to add anything on this? Creatinine and EGFR?
Of course, in this patient, I think creatinine is, I think should definitely trigger the physician, attending physician to think of nephropathy. But in a patient who has 65 female and creatinine of 1 or 1.1, don't always make sure that you do an EGFR, then only you can do the grading. Because if for a lady, when you do your EGFR calculation, they fall a grade, I mean, their EGFR actually decreases much more than a male. So the gender is very important. So just as I said before, creatine per se may not be an idea where you can, you cannot just look through the creatine. You have to get an EGFR on the side. And I have in my medical college, since I'm working there, I make sure that all my records, you have an EGFR written so that even if the drug dosing, all those, your treatment protocol will be based upon the EGFR. And as you know that as chronic kidney disease advances, progression happens, I think EGFR will play a very role for at least for the patient also, because we are talking for the patient. Adherence happens only when the patient knows that he has this problem and he has to be taking these medications, especially the salt intake. So all these things we can prime them only when we have some numbers which any person can, take a cognizance of it. But if you just say create 1.1, 1 point, he may not. So here you have a patient, A1C probably I won't take too much into care because looking at his age and CKD, maybe 7.2, 7.3 would be an ideal. 7.8 is fair enough for him. It's a fair control, not a good control. It's a fair control. But if you look at anemia, as Damodaran sir said, that anemia plays a very important role. You cannot nullify at creatine, hemoglobin of anything 11.5 and below. We always take for granted 11. Okay, for Indian setting, it is okay. I think it cannot happen. We need to get hemoglobin above 11.5 for each and every patient.
Yeah, I think monitoring creatinine and EGFR especially is important because if the EGFR falls down, then even the diuretic you may have to change instead of chlorthalidone. The EGFR is less than 20, you will have to change to torsemide or Lasix. Also, if the ACE inhibitor is there, if the EGFR comes down, you should think twice before you continue EGFR. And I think the monitoring in these cases are very, very important, especially what he said, proper follow-up with EGFR and creatinine is good.
I think we should not wait for the creatinine to deteriorate. It's very late parameter.
Yes.
So we should try to investigate and try to detect by the ACR. Albumin creatinine ratio is the thing which can give us the earliest indication of deterioration of the thing. And we can think about that this patient might be to renovascular hypertension. So we can take the appropriate steps. We can fix up the medications accordingly. If we are thinking about the renovascular hypertension, we have to treat it up to the target 130/80 very stringently, preferably with the RAS blockers using that. So these kind of the things should always remain in our mind that if we shall be doing the ACR first as an investigation.
Again, potassium you must monitor because if the potassium goes up, the selection of diuretic like spironolactone you should wait because if the potassium is more, it's better not to give spironolactone.
See here, the urine albumin creat ratio is 1,200 milligrams per gram. So anything more than 300 is taken as albuminuria. And next is the echocardiogram shows an ejection fraction of 48%. And there is concentric LVH. Any comments on that? whether we should do an echo in most of the patients with hypertension. What is the value of doing an echocardiogram? See, many times when we tell patients to get an echo done, due to cost and other reasons, they would not like, they may not be compliant. So what is your
I
comment
believe
on doing an echo on
it-
these patients?
I believe in India, every naive hypertensive and every naive diabetic should be exposed for the 2D echo.
Very
Because we have seen a number of diabetic, hypertensive, and sometimes those who are alone diabetes or alone hypertension, they are coming with left ventricular hypertrophy, and left ventricular hypertrophy is also making them further deterioration. So this patient is clear cut is in the failure. And we can already the clinician has kept him on the diuretic, as well as ARB. Both are taking care. Lisinopril is being given. So ACE inhibitors is good enough, and with the diuretic who is taking care. But the most important thing is to keep the blood pressure up to the target level. That will only help, and nothing is going to help anything any more than that.
Yeah, in fact, ECG may show LVH, but more specific and sensitive is echo. So all the patients with hypertension, echo must be done so that, we can find early LVH and we start treating aggressively. LVH can regress.
In addition to echo, a TMT is warranted. See, we don't just control the hypertension. That's what you do in general medicine department. If you refer them to the cardiology, they'll unmask the MI and carotid. Am I right, Kumar?
Yeah.
So
In this
here,
patient,
just pundits, but in practice,
and echo, why we want to do more is the sense that we have now moved to a stage where you do heart failure, whether it's a preserved or it is going to be, whether reduced or it's a mid-range. So our therapy also, whether to give an SGLT2 inhibitor or if it's an established atherosclerotic, with the poor cardiac reserve, I think that also become a very important, whether to give a DPP4 inhibitor for diabetes or to give an SGLT2 inhibitor. Probably echo can also throw a light on
Right.
what therapy you want to
So
do.
going by
in
the
addition to that,
investigations.
other thing which you don't do in general medical ward is the eye evaluation.
Yes.
Usually these people come to go to there with the blind, especially in the diabetic people who call self-site diabetologists, they just control the blood sugar. And our job is to screen for in chronic disease, both in hypertension and diabetes, you screen for, Professor.
So to summarize, this patient has early nephropathy with a low ejection fraction. What is the importance of controlling blood pressure in this patient? Do you think blood pressure control is absolutely important in this patient or not? JSK? Anuj, can you
No, in fact,
stress on that point?
no, in fact, if you don't control the blood pressure, one of the major complication for the resistant hypertension is heart failure. They have given ratios. So first complication, first problem is heart failure. So if you don't control, you cannot control heart problem, as well as if you don't control hypertension, the kidney damage also will be more. You see, the kidney is cause and effect of hypertension. So when you control hypertension, kidney damage also can be minimized. Heart failure also can be minimized. So as I said, kidney is culprit as an effect, as a cause for hypertension.
Thank you, sir. Can you have a comment on the,
Many
I
times, sir, it happens that in our country, when the patient comes to us with hypertension, 50% nephrons are already lost because of the hypertension. So in such situation, it is the utmost important to keep the blood pressure up to the target level if we don't want the nephrons to be lost further. So of course, the time is over.
exactly.
So we have this problem that when patient comes to the office in the morning, his BP may be within the range, but the problem in CKD is the nocturnal hypertension, which is probably masked, not seen. So this masked hypertension is something that only probably home blood pressure monitoring or ambulatory BP has to be considered for each and every patient, especially when the creat is going up or EGFR is dwindling down. Should be mandated.
Yeah, in fact, I agree with Karnanidhi and Ashok. When you control hypertension, you can prevent stroke. Once somebody has stroke, it's very difficult for rehabilitation. So prevention is the key. By controlling hypertension, you prevent stroke. 57% of the hypertensives are developing stroke. So that is why we say hypertension clinic, prevent hypertension, promote hypertension, registry hypertension, all that. So that's the message.
You want- we- Sir, I think a simple thing like hypertension control, which any doctor can do in any setting, is going to have major public health benefits. And that is the reason why this topic was introduced. Fine, sir. Let us finish and then we can have the discussion, sir, please. COVID taught us that good public health is the key. We can get over many problems by doing simple things. And by simple thing like controlling blood pressure can have major benefits and determines the health of the country. It is not the specialist or it is not the physician or it is anybody. Any MBBS doctor can do this very nicely and we can avert major problems in the society.
Yeah,
Now,
hypertension.
secondary hypertension is a different ball game. It takes a long time to discuss this. But when you diagnose secondary hypertension, I just have one point to say, sir, and then we will close. Time is over. Diagnostics testing at pitfalls. First, do biochemical localization of the lesion before you do a radiological investigation. When you deal with secondary hypertension, especially endocrine hypertension. Many times you find patients getting MRIs done, CT abdomens done, and then breaking their head as to what it is. It is an incidentaloma or is it something else? This will take more than 2 hours to discuss. But anyway, we just wanted to highlight that point that don't resort to imaging first and then do biochemical localization. Do biochemical first, prove what the lesion is, and then go for radiological investigation. That's all we want to say for secondary hypertension. Due to lack of time, we are not able to continue. I think it was wonderful discussing this very simple topic. It is not a big fancy topic. And I thank JS Kumar for getting the case ready and all the three panelists for contributing a lot. I hope you brought out the point to the audience. Thank you very much, sir. Thank you to all the panelists. Thank you for all the comments as well. Thank you.
Would like to thank all the panelists. And thank you, Damodaran sir, for finishing the session with such powerful messages and on time. Now we will move on to the next session. For this, we have Dr. R.P. Rajesh with us. I would request the other panelists of the session, Dr. Vijay Bhaskar Reddy, Dr. Shanmugavelu sir, and Sarita madam, over to the dais, please. Over to Dr. Rajesh.
So thank you. So respected panelists, senior clinicians, and my dear friends, over the next 40 minutes, a very good morning to you. Over the next 40 minutes, we are going to discuss about what are the treatment options in a diabetic individual if they are having a decline in their renal function. So without wasting much time, let me just straight away go into a very simple case which we routinely see in our clinical practice. So here we have a 61-year-old female having diabetes for the past 13 years, hypertension for the past 5 years. She comes for a routine checkup. You can see the BP is not under control. It is 152 by 94 millimeter mercury. BMI is also on the higher side, 32.9. And you can see the fasting blood sugar is 192 milligrams per deciliter, postprandial is 311, HbA1c is 9.1. So with all these things, we know that this is not a good controlled hypertension. This is a poorly controlled diabetes as well as hypertension, yes. And you can see the urea is 38 milligrams per deciliter. Creatinine is somewhere around 1.28. I just want to make a mention here. The laboratory's upper limit of normal range was 1.3. So with that, taking that into consideration, you can see the creatinine is 1.28 milligrams per deciliter. And I'm not going into the detail of all the other investigations. You can see the LFT, lipid profile, complete blood count, everything, baseline ECG, everything is within the normal limits. So this is the picture. But when we do further investigation, when you do a electrolyte level, you can see all the electrolytes are within the normal limit. Urine complete analysis was done, no deposits. Only thing, sugar was 2+. And when they did a ultrasound abdomen, what they found was a large sized kidney. So that was there. And again, when they did an off-the evaluation, what they found was a non-proliferative diabetic retinopathy. And when they did a urine albumin creatinine excretion ratio, you can see that should be less than 30, but you can see that is well above the normal range. It is in the microalbuminuria range, 126 it was. And at last, when they calculated an EGFR, you can see EGFR, there is a gross decline in the EGFR. It is 44.8, so which clearly tells you it is a stage 3 CKD. So just going on by the creatinine value alone, you can see it doesn't, we may easily miss a case of early CKD. 1.28 was the creatinine here. So I'm stopping with this here. Let us open up this for a discussion. We have eminent panelists here. As an Indian custom, let me start with ladies first. So I'm just going to start with Madam. Dr. Sarita Madam is here. She's a nephrologist. So my question to you is, Madam, why should not we diagnose an early CKD? Why cannot we diagnose an early CKD going by a creatinine value alone?
Okay. Good morning, everyone.
And if we want to diagnose an early CKD, what should we do? And if you want to screen a diabetic individual for an early CKD, how should we screen? And how frequently we should screen them? So this is my question.
Good morning. Thank you for the question. I think it's a very, very valid point that all our labs, they show a normal value of creatinine between, actually some of them even go up to 1.5 is normal, lower limit. So the importance, why did we choose, first of all, the creatinine as a marker of a kidney disease is because relatively it is produced at a steady state from the muscles, and then the kidney is the only one that puts it out. Therefore, creatinine is chosen as a marker. However, creatinine is put out through the kidney in two ways. One, it is filtered by the glomerulus, and most of the time when the kidney function is normal, it is all filtered portion, and that is why it measures the GFR. However, as the kidney function declines, most of the creatinine is secreted to the tubules. Therefore, the creatinine value does not rise in the blood. There's a compensatory mechanism that is happening by the secretion, and that is the reason why we are not able to use creatinine in the early stages. The compensatory mechanism is the reason. So how do we find out early? Well, kidney function decline in any patient is that we use two ways of detecting. One is a protein loss, and the second is the decline in the GFR. So to measure the GFR, we have 24-hour urine, which is difficult to measure. So in the beginning stages, we use the CKD AP formula, which can be downloaded very easily on the website, in the clinical, in your laptop when you're working as well. And that can be utilized to detect it early.
Madam, the thing is correlation between urinary albumin creatinine.
Correlation, albumin is anything more than 30 is abnormal, and more than 300 we call it severely increased. And protein.
How frequently we should screen for an early CKD in patients with diabetes?
Okay, how frequently? To me, I would say that being a nephrologist, the earlier the better. So every visit to the diabetologist, you should be looking at the protein creatinine ratio. I think I'll be confusing by saying protein creatinine ratio and albumin creatinine ratio. Albumin is the one that is detected early, that the marker is about more than 30. Protein is, we use it on a general area that is more than 100, 150 and more than 300 is abnormal.
So having discussed about, yes, sir,
Yes, Dr. R.P. Rajesh, previous session, Dr. Damodaran and Dr. J.S. Kumar, they were actually discussing about the dipstick proteinuria.
Yes.
So whenever we come across dipstick positive proteinuria, it has to be correlated with urinary albumin creatinine ratio. Just by simply doing dipstick positive proteinuria does not convey any meaning. Always correlated with urinary albumin creatinine ratio.
So dipstick protein is positive when the albumin, when the protein is more than 300. So anything less than 300, we won't be able to identify that on a dipstick. That is when we have to do the microalbumin. So, but by doing microalbumin, what are you going to do is identifying it early. That's basically what it is.
So having discussed about this urine albumin excretion ratio, let us ask from Dr. Vijay Bhaskar, sir. So how do you actually define a microalbuminuria? And when we do an urine ACR for our patients, if it is elevated, does it always mean that this patient is having microalbuminuria, or there are some other conditions, some other non-renal conditions which can actually cause an elevation in this urine albumin creatinine excretion ratio? So let us hear from you.
Madam has already told that microalbuminuria is the earliest stage of protein excretion, and the terminology has changed now. So people don't want to use typical term of microalbuminuria because currently the understanding is that the protein excretion is a continuum. So right from the minor amount to major amounts, it's a continuous albumin excretion. So now the terminology has changed from normal to mildly increased albuminuria, moderate albuminuria, and severe albuminuria. So previously we used to do a 24-hour urine sample and estimate the 24-hour urine albumin excretion. And there anything more than anything more than 30 milligram per day is considered as microalbuminuria before. But now we don't do this 24-hour urine because patients will not cooperate. And if you want to do frequently, it's not possible. So what we do is a spot sample, spot urine albumin creatinine ratio. So anything less than 30 is considered as normal albumin excretion. 30 to 300 is moderate albuminuria. Previously, this group was termed as microalbuminuria, but now the terminology is moderate albuminuria. Anything more than 300 milligram per gram of creatinine is severe albuminuria. So this is how it is. So previous terminology, we can change it to moderate albuminuria. Then anything 30 to 300 is the range where you develop this microalbuminuria or moderate albuminuria. So there are other conditions which can cause microalbuminuria, especially when there is marked hyperglycemia, exercise within the previous 24 hours, fever, infection, urine infection. And so these are all conditions we need to watch out. So fever, urine infection, and any fever for any cause, exercise, and hyperglycemia itself can cause this albumin excretion. So ideally it does uncontrolled hypertension also. So we need to reconfirm this. So just on a single sample, we cannot jump to the diagnosis of microalbuminuria or moderate albuminuria. We can repeat it after a month or 2 months, and 2-3 times we can check, and then we can confirm. Yes.
Sir, yeah.
From diabetic point of view,
Yes.
Cardiovascular, 200 times of the number, it has the LDL for it.
Yes.
But practice, microalbuminuria is not that sensitivity or that. How you know about our lab? I can't say everything is your lab, but at the same time, being at a board certified pathology here. Is there anything now we know about proteomics, protein marker? Is there anything in the fight? Microalbuminuria or rather than micro, is there anything we can do at least in the near future? But in practice, what we do then, we have 1.5 or 2. Going to go to the after management. What the example is now learned. This is what this is how this thing we got application. So it's proteomics. There are a number of things for acute which is done in the So from your clinical observation of the
Nice. Thank you for that, doctor. I think more than any microalbuminuria, before retinopathy itself, the microalbumin comes up. I think the reason why we focus so much on the protein leakage is that it is a early warning sign. Even before any other organ gets damaged, protein leakage is happening through the kidney. It is the earliest sign, and so we focus on that. I don't think there's any other proteins that will give you cost-effective treatment value. Practical value-wise, I don't think at this point we have anything. So,
Madam, what is your
Again, as sir has told you already, microalbumin or protein, anything can be depending on the circumstances. Patient exercising from the gym, coming and doing the test, or even under stress for fever or any other reason, and then coming up with a microalbumin, you have to just repeat it. And again, okay, you diagnosed microalbuminuria. All we are telling the patient is, please control your blood pressure, please control your blood sugar, please control your cholesterol. Do not take any medicine that can hurt. I mean, this is all we are going. We're going to do it that at any point, at any way, always. So focusing only on this, only to highlight it. So warning the patient to be more careful about themselves. I think that's all that we are.
If
actually
possible,
planning on.
measuring cystatin C. So combining two filtration markers like EGFR and the cystatin C, it may provide a very great confidence regarding the clinical decision making.
I agree, sir. Cystatin is only a marker of an acute kidney injury. But what is it that you're going to do about it other than correcting what we're anyway going to correct? So yes, doing it. What are we going to do more than that? That's, I mean, as a clinical, I'm more practical in approaching. So I would say, yes, you can do any number of markers. What is it that is going to give you in your management? Is it
Yes.
going to change your
Change.
management?
Yes.
So micro, yeah. Yeah, nephrotoxic agents, definitely. I think any drug for that matter, which is not required, should not be taken. And statins, we say it's not nephrotoxic. However, last few months, we have been treating patients with acute renal failure because of rhabdomyolysis from the statin. So it's not like one something is toxic and something is not toxic. Some we know they're obviously toxic. Some we have to adjust the dosing for the kidney function. So that's where the importance comes in. Every medicine, judicious using
Correct.
is more important
Exactly.
than anything.
Exactly. So now we have made a diagnosis of CKD and we have picked it up in the early stages. So let us hear from Dr. Shanmugavelu sir, whether this patient is having a diabetic kidney disease or forget about this patient. In general, if we diagnose a CKD in a patient with diabetes, does it mean it is always a DKD? Or
The
whether
thing
there are
is,
there
yes.
are other non-diabetic causes also which can contribute to it. If it is so, how common it is and how to differentiate between a diabetic kidney disease and a non-diabetic kidney disease. So let's
Right.
hear from you, sir.
If a patient has diabetes with evidence of retinopathy, albuminuria, and associated neuropathy, diabetes of longer duration, we normally think that due to diabetic nephropathy, CKD. Right. Sometimes we do get absence of retinopathy even in patient with the type 2 diabetes, number 2. Third important thing is we have normal albuminuric
Exactly.
CKD in patients with the type 1 as well as type 2.
Exactly.
When to suspect non-diabetic cause for CKD, absence of retinopathy, number 1, diabetes of shorter duration. When the patient presents with massive proteinuria or progressing increase in albumin excretion, number 3, progressive or rapid decline in EGFR. And when they present with systemic illness or signs and symptoms suggestive of systemic, for example, SLE, like that. Next is when we come across a resistant type of hypertension. When you do urine examination, when you come across sediment abnormalities, presence of red cell, presence of white cell, presence of cast, acanthocytes, this will throw a light on non-diabetic cause for CKD. Next very important thing is you are putting the patient on ACE inhibitor or ARBs. If there is a decline in EGFR more than 30%, and if it is progressive, then we need to raise our eyebrows that we are dealing with a non-diabetic cause for the CKD. And that is a time for us to refer to a
Yes.
nephrologist.
Yes. So madam, is it really needed to differentiate between from a diabetologist point of view? Do we actually have to differentiate between a diabetic kidney disease and a non-diabetic kidney disease? Does it have any prognostic significance or does it have any difference in the management? What is your
Absolutely.
take on that?
Absolutely. As Dr. Shanmugh will already mentioned, every diabetic need not have a kidney problem. So only 30% of the diabetics have a kidney disease. And every kidney problem in a diabetic need not be because of the diabetes alone. It is important to differentiate because it patient could be having an atherosclerotic, maybe they're having an renal artery stenosis, maybe they're having IgA nephropathy, glomerular, which is most common in India as well. The treatment of which is completely different from that of a diabetic management. If we are very sure of a diabetes, then yes, we go ahead with the diabetic management along with the other things. However, if it's an IgA nephropathy or if it's an infection related, then the treatment is going to be different. And as usually those will be of steroids, and we don't want to give any of those without having a definitive diagnosis, especially in a diabetic patient. And therefore, it is, as the management is going to be different, we have to look for the signs and symptoms of it not being a diabetic, especially in the progression is very fast, and we have to address it at the earliest by biopsy, which will confirm, and only after that we'll be able to make a final diagnosis and the final treatment.
So the
Yes, definitely, definitely. There are some hepatitis patients who have diabetes as well. And those people, we all assume that it could be only diabetic nephropathy, wherein they also have a hepatitis related infective glomerulonephritis, which we were treating in different ways. So, and there are IgA nephropathy patients as well. So many times we do have diabetes might be there, but that is not the only thing. So they should be looking with all the warning signs that doctor has mentioned. We have to consider biopsy, and biopsy is not dangerous, and it is easy to perform with a very significantly low risk. So I think it is definitive answer is always good.
So the point, yeah.
We know that it's poorly controlled diabetes, patients, families, hypertension, but smokers like that. But if they are, what is the molecular mechanism? I don't think we have a way of predicting that, okay, this diabetic will definitely develop nephropathy, but I think the albumin leakage is the number one. Secondly, family history also I think does matter. Other than this, I don't think I know of anything that can definitely say, oh, you're diabetic, so definitely you're going to develop a nephropathy. Not much.
Yes, madam. So the point which we want to emphasize here is that when you diagnose a CKD in a patient with diabetes, it is not that every case it is a diabetic nephropathy. So there are other reasons, non-diabetic reasons for it, which we have to probe into it. And Shanmugal sir has highlighted beautifully how to differentiate between a diabetic and a non-diabetic kidney disease. So with this, we'll further move into this case. Yes. So what we saw earlier was that the blood glucose control is not at all optimal. You can see the HbA1c is 9.2 and the blood pressure is also on the higher side. So what we have to do is that we have to prevent the progression to the further stages of CKD. So that is what we have to do. So for that, we need to get a good glycemic control, an optimal BP control, all these things we have to get it. So let's hear from Shanmugal sir. For the glycemic, the HbA1c here is 9.2. So what kind of a target do you want to achieve in a patient with a declining renal function?
Yes, first of all, we have certain limitations as far as A1C measurement is
that's
very,
the
very
second thing which I wanted to ask you. In case if you want to monitor the glycemic control.
Yes, okay. I'll combine
whether we
both.
can fully depend upon HbA1c, or you want to complement it with some other CGM, or you want to do an SMBG.
SMBG,
Like
yes,
so
yes. Of course, first A1C, patient with the type 1 and patient with the type 2. Patient with the type 1 CKD stage 1 and 2, I'll keep it around 7.5. CKD 3 and 4, 7.5 to 8. CKD stage 5 or dialysis, I'll keep it around 8.5, type 1. Similarly for type 2 also. With reference to A1's limitations, there is a carbamylation because of raising urea level. That carbamylation leads to generation of isocyanic acid, which can bind with the lysine and arginine residue of the hemoglobin. So we normally get with the conventional methods of measuring HbA1c. But this is eliminated if we perform by HPLC, which is certified by NGSP. That is one. Second thing is there is reduced lifespan of RBC because of hemolysis. And we normally come across iron deficiency anemia, which can give rise to falsely low levels of A1C. And we put the patient on erythropoietin or blood transfusion, which may favorably altered the A1C level. So these are all these certain things we need to focus our attention, number one. Apart from A1C, we have other fructosamine assay or glycated albumin. So these are all other markers by which we can assess the glycemic status within a short period of time, say 14, that is 2 weeks to 3 weeks with reference to lifespan of albumin. But again, patient present with nephrotic syndrome or cirrhosis of liver or patient with hypothyroidism, again, the values may change. And fructosamine and glycated hemoglobin albumin assays are not available everywhere. Still, the KDIGO recommendations or DADA, again, A1C. Next is, very important thing is A1C gives an glycemic status over a period of 3 months, right? But patient may likely to go for hypoglycemia or hyperglycemia. So best thing is put the patient on SMBG, or if it is if the patient is affordable, we can go for the intermittently scanned CGMS. So we can minimize hyper, we can minimize hypo, we can able to achieve optimal levels of glycemic control.
Exactly.
No, the thing is, just now we are discussing about, glymipride, I will not.
That's
I
what
will
we are
not.
going
Yes.
to ask. Let us hear from Dr. Vijay Bhaskar, sir. So that's what we are going to discuss. So we know that the HbA1c is 9.2 here, and we have to keep a target close to 7 in this patient. So let us discuss about the molecules. So when it comes to when it comes to metformin, always there is a confusion whether we have to continue it, when we have to stop it, or when we have to reduce the dose. So let's take it from you, sir. What about the dosage of metformin? Where we have to stop it, or should we have to reduce it? Or again, Dr. Karnanidhi has wonderfully raised a question about the glimepiride. So whether we can continue the same dose of glimepiride. So what is your take, or about DPP-4 inhibitor? So all these things, a quick
think,
from you.
One aspect is the current 2 standard medicines for diabetes, what we use, sulfonylurea and metformin, they are in full doses. Probably for that level of CKD, the doses are high. So despite that, the glucose control is not good. So we have to look at other options. Regarding metformin, initially the textbook recommendation was creatinine 1.5 in males and 1.4 in females. We have to stop metformin. But now mainly that concern was mainly because of the risk of lactic acidosis. But over time, people have been using metformin at lower levels of eGFR also. It has been understood that lactic acidosis is very rare, especially if we are cautious enough to avoid when the patient is unwell. Patient is not well, we should stop using metformin. So if you do that.
So you go by the creatinine value to titrate metformin dose, or you go by the eGFR?
So now we have to look at eGFR, because already what has been discussed, creatinine may not clearly show the eGFR status. So 1.2 creatinine, you may feel it is okay, but eGFR will show, like in this case, 44 ml per minute. So we should go by eGFR. So only creatinine value may not be accurate. So we should do an estimated eGFR based on the, as Madam told, based on the CKD EPI formula, which is easily downloadable. So current recommendation for metformin is eGFR less than 30, then we have to stop. So that is the cutoff. eGFR less than 30, we have to stop. Less than 30 to 45, we can use, but half the maximal dose. So in this case, metformin 1 gram twice a day. So we can give around 500 milligram twice a day, or 1 gram per day total. So that much amount of metformin is still allowed now, which was not allowed previously. So eGFR 30 to 45, we can use half the maximal dose, and more than 45, you can use metformin freely. So less than 30 eGFR.
Sulfonylurea?
So sulfonylurea, there is a risk of hypoglycemia when we use at lower eGFR. So we can restrict to 2 milligram once a day.
Okay. Can we use DPP-4 inhibitors here?
So we can add the next drugs which are there. In this case, we should use a SGLT2 inhibitor, because that will protect the kidneys also. So that is at current recommendations are eGFR more than 20. Still, we can start using the SGLT2 inhibitor, one for glucose control and second for kidney protection, cardiac protection also.
So in this regard, let us hear from
No, that's what we're coming to, sir. So
Yeah,
irrespective of what you're going to use, we have to use SGLT2 inhibitor. And straight away, we are looking at insulin therapy in this case. Insulin also. Yes.
yeah. 100% we have to use insulin here. There is no doubt on that. But when we have to continue metformin, can we continue with the same dose or we have to reduce it? That's what we are discussing now. So you just spoke about SGLT2 inhibitors, sir. So let us hear from Shanmugavelu, sir. So now we have evidence to show that that SGLT2 inhibitors are cardioprotective. They are renal. They
Slow down
yeah,
CKD.
yeah. So they are just like disease modifiers in patients with CKD. So can you tell us the role of SGLT2 inhibitors as disease modifiers in CKD in patients with diabetes here?
Yes, of course. Patient with multiple risk factors for atherosclerotic cardiovascular disease, multiple risk factors for CKD, we need to put the patient on SGLT2 inhibitors on the top of metformin, which we consider as a first-line therapy for management of hyperglycemic patient with the type 2 diabetes. With onset of CKD, the risk for cardiovascular events are very high, number one. The risk for heart failure is also very high. And the risk for progression to end-stage renal disease, the need for renal replacement therapy is very high. So these three renal events can be, to some extent, reduced by putting the patient on SGLT2 inhibitors. Any currently available is like canagliflozin or dapagliflozin or empagliflozin with the primary aim of improving the renal outcome as well as cardiovascular outcome, because it is associated with improvement in glycemic parameters, reduction in the body weight, favorable impact on the blood pressure, especially it alters the hemodynamics. It reduces the interglomerular pressure and slows down the progression of CKD.
So till which
We give, but the thing is, we need to educate the patient before we prescribe.
correct, exactly. No, that is that see, insulin is actually given to reduce the blood glucose level, but the role of SGLT2 inhibitor here is a renoprotective role.
That is
So we
apart
have-
from
we have-
glucose
we have-
lowering,
we have-
apart from glucose lowering, it has a pleiotropic effect, and the very important thing is cardiovascular
Correct.
event improvement
Correct,
as well as renal improvement.
correct,
With insulin, we can reduce the glucose level.
right. So again, as Dr. Karunanidhi rightly said, giving alone these oral tablets are not going to be enough. So ultimately, we require insulin. So when we want to use insulin, let us hear from Sarita madam. What type of insulins can we use here? What type of regimen can we use here? Or do we have any dose modification in insulin dose with respect to the EGFR? So let us hear from you.
Absolutely. Insulin is the drug of choice in as far as once the patient develops a kidney problem, insulin is a preferred choice. As far as the sugar control is concerned. In the early stages, that is the stage 3, stage 4, we give a normal doses of insulin, but as it comes down 50% from stage 4 onwards, and stage 5, that is dialysis patients, we go by reduce the dose further to 25%. The type of insulin that we are talking about, we can actually, we prefer, actually, as Sir had said that we want a HbA1c on a higher side, not just HbA1c. Basically, what we mean is hypoglycemia is more dangerous than a hyperglycemia in a person who has already lost his kidney. So we try to keep the sugars about between 120 to 150 and not more than that, nor very low. So while trying to achieve that, and kidney patients also have two problems. One is that they also have some amount of insulin resistance requiring a little bit higher doses. And on the other hand, because insulin is not getting out of the kidney, the patients are also prone for hypoglycemic events. So we try and give the short acting insulins, which are preferred. So we don't go for hypoglycemic events.
So if the
short
patient
acting
is
lowers the
affordable,
dosing.
if the patient is affordable, do these analogs have any edge over the
Definitely,
conventional
analogs are better because
with
of their
respect to
short acting.
safety,
Yes,
with
yes.
respect to
Quite
hypoglycemia?
relatively safer than the regular.
Yeah.
Yes, analogs are better.
Yeah. Thank you.
Short
So,
acting.
yes, so Dr. Vijay Bhaskar sir, so the patients blood pressure, you can see it is 152/94. So we have to bring an optimal control of blood pressure also when we want to retard the progression to further stages of CKD. So in this respect, what is the blood pressure target you aim for this patient? Where do you target 130/80? Where do you relax it somewhere around 140/80? So what is your take on that? And again, when you want to reduce the blood pressure, what molecule you are going to ask? Do these ACE inhibitors or ARBs have an additional edge over the other molecules? So let us hear from you, sir.
I think, as you rightly told, blood pressure is not under optimal control. 152/94 is high. Because this patient has got albuminuria also, already we saw this patient has moderate albuminuria, around 124 milligram per gram of creatinine. So patient has got albuminuria and EGFR is also showing 44 ml per minute, which is stage 3 CKD. Definitely antihypertensive has to be escalated, and it has to be ACE inhibitor ARB because they have additional renal protective effect that reduces the intraglomerular pressure. So those are the ACE inhibitor ARB will be the next option in this case because of the albuminuria and reduced EGFR. But when you start the ACE inhibitor ARB, we have to monitor the renal function and the potassium levels also. As Dr. Shanmugavel said, told already, up to 30% rise in EGFR we can accept, but anything more than 30% rise in EGFR when we start the ACE inhibitor ARB, then we have to become a bit cautious. Target would be at least 130/80. In this setting, at least 130/80 and below is what is recommended because that's what gives the kidney protection. But if the patient, normal diabetes patient without any CKD or albuminuria, we can accept up to 140/80.
So we know that ACE inhibitors or ARBs are also renoprotectors. So we have to start these molecules here. So suppose we start this molecule. So you're going to start any one of these molecules. So and you have told clearly that how you are going to monitor these patients. So let us hear from our nephrologist here. When do you stop these RAS blockades, ACE inhibitors or ARBs? When should we stop?
When should we stop?
Yeah.
Rather than when should
Just
we
looking
start?
at the
Yeah.
creatinine, can we stop, or we have to look into the potassium level, or
Yeah.
what we have to exactly do? How to move?
Basically, definitely, there's no question on when should we start. We should start on any patient who has a protein leakage or who has a diabetes and hypertension. Definitely, the role is more when there's a protein leakage. When do we stop is when, as sir has already mentioned, 30% increase in the decline in the GFR. Basically, again, when you look at that, why do they drop their GFR is usually when they have a co-current conditions like a pre-renal conditions. Maybe the patient is having such uncontrolled diabetes, which is having a diuretic effect, and therefore they're already in a pre-renal status. And that is when you're adding this ACE inhibitor on ARB, the GFR is dropping. So I think hydration, if you place a more importance, then we may not have to stop the thing. Other thing, look for the reasons basically. GFR dropping despite correcting all the pre-renal factors like starting a diuretic at the same time as that of an ACE inhibitor, or if the patient is already on an SGLT2 inhibitor, which is also causing diuresis, or the patient is not taking adequate water. So all the pre-renal conditions should be corrected. Despite that, there's a decline in the GFR is probably telling us that this is not the patient who will tolerate the ACE inhibitor. These are usually the elderly hypertensive patients who have a vessel disease. The other group, other areas when we want to stop it is when we have potassium problems mainly. Today's day, there is no guideline on saying that, okay, your creatinine is, or your EGFR is 30, you should stop the ACE inhibitor. No, the only thing is this, as long as we're able to control the potassium problems and keep it below 5.2, I don't think there's any indication to stop an ACE inhibitor irrespective of the GFR stage.
Suppose
the
if the
CRF
potassium is
stage.
5.5 and we have still not started any strategy to reduce the potassium level, should we stop an ACE inhibitor there,
ACE
or
inhibitor-
should we do anything to reduce the potassium
I think this
simultaneously with
class
continuing
of drugs seem to have proven above and beyond the benefit on the cardiovascular as well as the renal. So we should make every attempt to keep it on board
Yes.
and try to correct the factors as much possible.
Only
So
if that is not possible, then
only when it is not possible is when we have to remove the ACE inhibitors. For potassium, for that matter, in a kidney patient, in addition to that, I mean, diet especially, what we talk to them is, we don't try to tell them, don't eat this, don't eat that, but we tell them, okay, blanch your vegetables, cut the vegetables, put them, soak them in the hot water for about an hour and a half or so, remove the water and use the vegetable the way you want to use it, including the green leafy vegetables, which have a high amount of potassium. So that way, they don't feel like they're restricted too much, and therefore they're also allowed to have and continue the ACE inhibitors.
so, yeah.
Cross blockade useful. So that is one question. Second thing, sir, Vijay Bhaskar sir, said, does metformin really cause an lactic acidosis, or it just causes an increase in the lactate, sir? And third thing, when we control this, the target was told 130/80. They said there are lots of, especially in Accord and Sprint, they said when you control the blood pressure to such a target, it is associated with the increase in the worsening of the kidney disease also, even in the presence of controlling proteinuria. So should we really go, especially in this case, to a target as low as that? So these are the two.
I think
அவங்க சொல்லட்டும் sir.
Actually, okay, we'll listen to the answer.
Sir, first, sir, please listen the answer by.
Sir, you can continue, please, sir.
so regarding lactate with metformin, so if you use judiciously and avoid the use of metformin acutely ill patients, there is no risk of lactic acidosis. We can use it. Suppose the patient is admitted in hospital with sepsis, or patient is acutely unwell, patient is hypoxic or heart failure, then you have to stop. That is the only risk when you can develop this metformin-induced lactic acidosis. Otherwise, it can raise lactate minimally, but full-fledged lactic acidosis only when acutely unwell. Another question you asked was about the blood pressure target. So we have to, not for everyone. So I think the middle path, you should not go aggressively. The lower the better concept is not true for blood glucose and for hypertension. The lower the better is true for cholesterol. How much ever low you go, you get benefits for the heart, but not for diabetes and hypertension. We need to pick the cases where we want very good control. We need to pick up the cases where we want average control. This setting is for very good control. If the patient has got protein albuminuria and patient has got mild CKD, this case, you need to keep the blood pressure 130/80. I would prefer 120/80 also in this case.
That is on an individual basis. You can titrate the dose in such a way whether the patient really gets benefit. Because once you reduce more than 30% of urinary albumin excretion, and if it is maintained for more than 2 years, definitely this is associated with reduced cardiovascular endpoints as well as CKD endpoints. Yes, yes. On an individual basis,
You have a question, please.
follow meticulous.
Please.
So I have one.
Gastroparesis. That is why I was again thinking before. All many of our diabetic patients are gastroparesis. Your analog at quickly is analog and the food delay very lately. So you could take hypoglycemia. That is not that we are against it. Listen, the diabetes is bad.
Meanwhile, I have
points I
projected
want
the
to raise
take-home
here.
messages. Other people can read it. People,
Yeah,
you can discuss.
Yeah. Actually, I have one point. That is patient of BMI is 32. I would like to rule out sleep apnea as the cause of uncontrolled blood pressure.
Excellent.
That is an point
Absolutely,
I think.
absolutely. Very, very common
Number-
condition.
Number
Very
two point.
under-recognized condition it is.
Number two, this patient has BMI 32, already on glimepiride. If we add your this insulin, there will be further weight gain. I would
Insulin.
prefer SGLT2 inhibitors a drug of choice. This type of patient, I treat metformin, SGLT2 inhibitors, and then add insulin. Because giving sulfonylurea together with this, lot of risk of hypoglycemia is also there. Or if I have to use actually a acetagogues, then I prefer a ripaglinide if patient can.
Actually, this patient,
Sometime we use a GLP-1 receptor agonist for postprandial control.
if cost is not a major factor
Yeah.
for the management of CKD and weight obesity, we have to prefer to use GLP-1 receptor analogs as well.
Analogs, yeah, that's. the-
They're
Thank
coming
you
up.
very
For
much.
On the
lack of
top-
time, I
on
think
the
we have
point
to
of sleep
conclude the session.
apnea, so on the topic of sleep apnea, it's true that obese people have sleep apnea, but even non-obese people do have sleep apnea. And that has to be considered on anybody whom we are unable to control the blood pressure. And that is one of the main reasons of the nocturnal hypertension, which is not diagnosed. And the number of 130 that is being told, I'm happy with that because we didn't say 120. We said 130 and above, because if you are aiming at 130, in India, I think we can at least achieve 140. So that's where we should be talking to them, I guess. That's it.
SGLT2 inhibitors actually slow down the sleep apnea related problems.
Wait.
So, I'll talk to you later.
So for lack of time, we will conclude this session. And all the panelists will be available in the hall. So please, audience, if you have any doubts, we are always here to answer the questions. So thank you. I really thank all the three wonderful panelists here. We had a really useful session. And thank you so much, all three of you. Over to Dr. Gauri.
Thank you, Dr. Gauri and Dr. RP, as well as Dr. Krishna G. Sheshadri.
Thank you, sir. Sir, Shanmuga, sir, you can continue to chair the next session, sir. I would like to sincerely thank the other panelists and Dr. RP Rajesh for an exciting session. Now we move on to the next session. Dr. Shanmugavel sir will be chairing the entire next 1 hour. So over to you, sir. Thank you, sir.
So very good morning to all the delegates assembled here. It's my privilege, happiness and honor to invite Professor Dr. Shashank or Joshi sir. Sir, please come on to the stage. Yes, sir. So Professor Dr. Shashank Joshi, he doesn't need any introduction, but it's my privilege and honor to introduce Professor Dr. Shashank Joshi, MD/DM, FRCP, FSCP, and he's endocrinologist currently in Mumbai, Lilavati Hospital and Bhatia Hospital, and he's a recipient of Padma Shri Award. And I request Professor Dr. Shashank Joshi sir to take us forward through his talk on moving forward, gaining a wider outlook of diabetes management with generation 2 basal insulin.
Thank you so much, chairpersons. At the onset, I want to thank Krishna. Somebody's mobile phone is here, so can I give it to the organizers? Somebody's mobile phone is here. So, I'm going to speak on moving forward, wider look on Gen Next basal insulin. These are my dualities and conflicts of interest. This is a sponsored talk by Sanofi, but I have to thank Krishna, Dr. Arvind, Sanjay, and of course, our mentor, Dr. Prasanna Kumar. These are my duality and conflicts of interest. And really, the next generation basal insulin has arrived. So we all know that, we have new metrics beyond A1C now for effective diabetes management. We are looking beyond A1C to time in range and glucose variability. So these are the two new metrics which have come in. And we recognize now, and we have some data, not complete and conclusive and holistic data to suggest that the suboptimal time in range can lead to microvascular complications and mortality. And where the next gen insulins come up is probably they may have, from a pharmaceutical and a pharmacological standpoint, smoother PK/PD profiles. They may allow, injection time flexibility, and they may be non-inferior to other basal 2 insulins. So, particularly in people with type 1 diabetes. So that's where the real differential matters. Beyond that, really, there's not pretty much to go ahead. So is it really true that, are we really looking beyond A1C? Because A1C was also a metric on the half-life of the RBC, cell life of 120 days. Does GV really matter? Do we have substantial compelling data to show that GV matters? Yes, it does. There is some evidence to suggest that a large fluctuation of glucose can significantly impact lives on people with diabetes. And therefore, the global guidance is that it recommends time in range in glycemic variability as key metrics to effective diabetes management. Clearly, we have data now to suggest that CGM has been a game changer because there's a lot of wealth of data for glucose variability, for the highs, the lows, and greater is the time in range, lesser is the risk of complications, including retinopathy. So there are new recommendations. We want to have the green, the red, the yellow, and the super targets. So in type 1 and type 2 diabetes, we try to keep the time in range at 70%, the above range at 25 and below percent and 5%, and time below range at 1% below 54 glucose and 70 below 4%. So really try to keep your glucose between say 70 and 180 and try to see that it doesn't cross 250, which is the ketoacidotic threshold, and try not to have it below 54, which is severe hypoglycemia. However, people with older age or high risk, we need to have a little less time in range, up to 50%. And in pregnancy and type 1 diabetes, the targets are stiffer. In gestational diabetes, targets are stiffer, and in the targets are moving. So obviously, when we have suboptimal time in range, then there is a negative impact on lives of people with diabetes. And now there's some data. As I said again, the data is not very robust and substantial and reproducible, that for every 10% drop in time in range, there is a 64% increase in retinopathy in type 1 diabetes. So in type 1 diabetes, glycemic variability matters. And if our patients can afford, and if they can have a CGM on a type 1, that's really the optimal. So we are looking at optimalization, and that's really optimal. There is a 25% increased risk in peripheral neuropathy in type 2 diabetic patients with CKD or DKD. So if you have a patient with DKD, clearly, if you try to maintain a time in range, it's very compelling. It will salvage the kidney and the nerves both. And there's a 40% increase in the risk of microalbuminuria in people with type 1 diabetes. So in type 1, it really matters. In type 2 also it matters. And there is a 5% increased risk of CV mortality. So again, it has a life impact, and 8% risk in all-cause mortality in people with type 2 diabetes. So positioning time in range has been a huge challenge. In type 1 diabetes, in type 2 diabetes, and we've had all types of mix and match regimens in India. They have been anecdotal, they have been arbitrary, they have been evidence-based, supported by the industry. And obviously, we need to have time in range as a very simple complex. We don't want to make it complex. We need to have a clear direction. We need to validate it. And we need to empower our people living with diabetes so that they can keep their glucoses in range and avoid hypoglycemia and high glycemic peaks. So that's really the overarching philosophy. Now, does the next gen basal insulins, which are innovated by the industry, do they offer substantial advantage beyond reasonable doubt? And do we have some data to suggest in that direction? So here is a study because, the original gold standard insulin in the basal space was NPH. When glargine was discovered, U100, there was a 33% drop in nocturnal hypoglycemia. So there was definitely a substantial gain from NPH to glargine. But when people moved from glargine U100 to 300, was there a substantial improvement? So this is data from type 1 diabetic population using CGM as a metric, 16-week randomized crossover study over 8 weeks, looking at GV metrics, mean glucose levels, and mean A1Cs. And you could see that there was a 55% lower nocturnal hypoglycemia. So again, there appears to be some meaningful, statistically significant difference when you move from U100 to U300 on nocturnal hypoglycemia. And it also allows you flexibility of dosing. Because you know that if you have a flexible dosing timing between plus or minus 3 hours, it may offer you some advantage, particularly a situational variability with various day-to-day lifestyle experiences. So that's something which we recognize very clearly. Also, we know that there is reasonable data to suggest now, again in type 1 population and type 2 population, that if you look at the MARG, the mean amplitude of glucose variation, there is a decrease in within night glycemic variability twofold. lower with the U300 glargine. So some advantages in the glucose TIR metrics there. So in light of the glucose variability and time in range, when we compare second generation basal insulins, head to head, we have degludec versus U300 glargine. Now, do we have that type of data? So when we look at data, we start from the baseline, which is pharmaceutical and phase 1 data, PK/PD study in type 1 diabetes, Bailey et al. And Hesse et al. Then PK/PD data in type 2 diabetes, then RCTs in type 2 diabetes, then RCTs in type 1 diabetes, and real world evidence in type 1 diabetes. And you can see here various studies and various authors where they have looked at U300 glargine trials in CGM or TIR in this space. So let's quickly look at some of these spaces. This is a randomized double crossover euglycemic clamp study. What does it suggest? That when you use U300 glargine, it provides a less fluctuating steady state PD with a more evenly distributed PK compared to a degludec in OD morning dosage. That's all it says, 20% less. When we look at the glucose variability, there is a 22% greater insulin peak with degludec and a 23% lesser day-to-day variability with U300 glargine head-to-head with degludec. When you look at T2DM CGM study of TIR, head-to-head U300 glargine versus degludec, again randomized, you can see that it's comparable, except that the TBR, time below range, is markedly lower. So it causes less hypoglycemia compared to a degludec. This was the flash glucose monitoring study. Again, it showed lower hypoglycemia. So the only thing which I can tell you as a take-home point for clinicians is that the nocturnal hypoglycemia is possibly lower with U300 glargine compared to degludec. This is real-world evidence from the OneCare study with type 1 diabetic adults. Again, using CGM, because now CGM is almost a standard of care in many countries like UK, US, Japan, where they use CGM and it's given free by NHS or the insurance companies in the US to the type 1 population. I hope one fine day we have that in India. It's low cost. It's available to our type 1 population. Type 1 population, it makes a difference. Type 2, I don't know. We don't have substantial data to see that point very clearly. Then, we have basal plus versus degludec aspart with FGM. Now, we know that premixed insulins have their own late limiting steps. They may be convenient, but they have some challenges. They have some inbuilt challenges. And we can see here again that when you use a basal plus regimen with U300 glargine with glulicine, that's basal plus. The hypoglycemia is 7-fold less, nocturnal hypoglycemia 18-fold less compared to a premix of degludec aspart. And if you see the in-range study, again, these are head-to-head studies. You can see the various endpoints. Again, the time in range is substantially less. And you can see that U300 glargine is non-inferior to degludec in type 1 diabetics with similar hypoglycemia and safety profile. So my whole idea of this talk was to just tell you that we are today, when we are looking at newer innovations in insulin space, and we are going to get once a week insulin coming up soon also. But, in the basal insulin space, we have definitely moved beyond NPH to U300 glargine. And from U300 glargine, probably we might move further. But currently what I showed you is that degludec versus U300 glargine, probably there are some advantages. So again, we have understood two things. My first take-home message is that glucose variability matters. Whether you measure it by SMBG or CGM, it should be done. And you need to do mindful eating. You need to mix and match your food, insulin dose and timing, as well as activity. And if you get that matrix right with diabetes education, that's the first key. And glucose variability matters. So if you have a negative variability, it will impact lives of people with diabetes. What does the next generation basal insulin like U300 glargine offer? It allows you a little flexible dosing space. So in urban metros, like where I live in Mumbai, where people they reach late because of traffic bottlenecks. I see in Chennai, it's not so bad as Mumbai. I don't see traffic here. Yesterday, I had a seamless, I came here without any traffic. So I'm happy that there's no traffic congestion here. But sometimes our patients, if they are delayed, dosing flexibility matters. So it gives you that situational variability and advantage. It's a marginal advantage, but in people with erratic lifestyle, it matters. There's a lot of trials, all industry sponsored, mind you, very few government sponsored, and few of them are real world studies. But we have data to show that these insulins like U300 have advantage on nocturnal hypoglycemia. So that data is clear cut. So if somebody argues with me, that data is clear cut. Oral hypoglycemia, probably less. And rest of it pretty much the same in terms of A1C reduction. So as I told you that what does that next generation insulin offer? Lower overall and nocturnal hypoglycemia. That's all it offers. And I'm grateful to the organizers for allowing me to speak in this meeting. Thank you so much.
Thank you, Professor Dr. Shashank Joshi, for taking all of us through your presentation. And you have highlighted nicely the limitation with reference to A1C, its impact on glycemic variability, the correlation of glycemic variability with reference to diabetes-related complications, and the importance of TIR. We expect the patient with the diabetes to spend at least 70% of the day with the plasma glucose range of 70 to 180, and its correlation to retinopathy, microalbuminuria, and positioning TIR with reference to various categories of patient with the type 1 as well as type 2. And second generation basal insulin, how it is different from first generation basal insulin, and several RCTs conducted in patients with the type 1 and type 2, comparing Glorgine 300 IU with IDEG, clearly shown the benefit in terms of reduced overall and nocturnal hypoglycemia, as well as with reference to flexibility of time of administration. Thank you, sir. We'll take the question at the end. Now let us move on to next topic.
Thank you so much. You did my talk in one breath. So, you really are a true yogi. Please put your hands together to our chairperson.
Thank you, sir. Thank you. Thank you. Thank you so much, sir. Sir, please. Is the next? Yes. Because I'm an ad hoc chairperson, sir. Yes, sir. So now I request our Professor Dr. A. Jivanekrishan, endocrinologist from Chalaram Diabetes Institute, Pune, to make a presentation on lessons learned, 20 years of clinical experience with basal insulin. Over to you, sir.
Thank you. Thank you. Thank you, sir. It's a pleasure to be here in debate meeting. And let me have my slides. So I'm going to talk about basal insulin as a concept. It could range from NPH. We've come a long way from NPH to detumir to glargine U300 to degludec. So let's look at the experience with basal insulin. So if you look at a very ideal basal insulin therapy, it should have a long duration of action. It should have a relatively flat and consistency over time. Low intrapatient variability with no pronounced peak of action. It should be easy to administer and titrate, and it should have a favorable safety profile. So why should we look at basal insulin as a concept? Because we have fasting blood glucose and we have postprandial blood glucose. And it's very important to fix the fasting first. And we require overall glycemic control, and international guidelines and recommendations have suggested the need for basal insulin. And today, basal insulin is also relatively inexpensive and available in India. If you look at the Asian data, the higher the HbA1c, the greater is the fasting contribution. Both fasting and postprandial contribute to the A1C, but the fasting has a very good, very high contribution to the HbA1c. And if you look at the concept of basal insulin, now if you look at the basal insulin, this is the basal sugar, if you like, and the post-meal sugar. If you can bring the fasting sugar from here to say here, the entire band could shift down. So bringing down that fasting with basal insulin will shift that band down and improve the amount of blood glucose that you have in the normal range. And that is the concept behind basal insulin. Does not mean that the prandial insulin has no role or the prandial sugar should not be controlled, but fixing the fasting first may have implications, because giving that once daily long-acting insulin may give rest to the beta cell, make it more receptive to the oral pills as well. So let's look at holistic glucose control. And if you see basal insulin, it improves the HbA1c. It improves a 2-year follow-up study. improves the fasting glucose, improves the postprandial glucose. This is our landmark study, which I think will be alluded to by the next speaker. So if people who are inadequately controlled type 2 diabetes, if you look at basal insulin glargine, you have good improvement in parameters such as HbA1c and fasting. So the fasting, you can see the A1C coming down from by about at least 2 percentage points, and the fasting coming down from 215 to 122. And that's very well known with basal insulin. And then let's look at the guideline recommendation. Now, if you look at the American Diabetes Association guidelines, they say that if the A1C is above target with maybe 2 or more oral drugs, in today's world, there may be multiple oral drugs which we can use, because after all, injection insulin is an injectable. You can start with either 10 units per day or start with 0.1 to 0.2 units per day and set the fasting target. There are 2 ways to set the fasting target. You can tell the patient to follow a self-titration algorithm. And there's another protocol where you increase the insulin by just 1 unit every day till the fasting comes down to the target you have set it for. And the target you set it for could be 110, it could be other targets. But if you see, both these are options for you. And basal insulin, the advantage of using a basal insulin analog is that unlike previous times where we were always worried about hypoglycemia, you can titrate the insulin to reach targets without much fear of hypoglycemia. If you look at our own Indian RSSDI guidelines, they say that if the A1C is high, you can start with either 10 units per day, or you can start with 0.1 to 0.2 units per day. And if the A1C is more than 8%, please read it as more than 8%. Again, you can give a little bit higher dose. Many times we start with 10 units, but 10 units may not be enough. If you take a 60-year-old or a 80 kg person, you might like to even start with 0.2 units, 16 units if the fasting is very high. There's good years of experience for basal insulin, because you can see the target achievement of targets is very good. The light blue skyscrapers show you the initial HbA1c, and the dark blue show you at the end of 6 months or end of the study. And you can see in all the studies, the A1C comes down significantly. You can see the pre-breakfast values also come down, and you can see that compared to, even if you look at, say, co-formulations, you see a benefit with basal insulin, and hypoglycemia is also lesser with basal insulin compared to idagasp. And if you look at the glucose lowering efficacy, if you look at the pure glucose lowering efficacy, you will see that, yes, premixed insulins control hyperglycemia like basal insulin, but are associated with more hypoglycemia and weight gain. So if you look at a car driving on the edge of a mountain, and if you see the car going, as a patient with diabetes, our goal is that the car remains on the track. If the car goes to the right, the car may hit the mountain. But if the car goes to the left, it may fall off the cliff. Even if it hits the mountain a little bit, it's okay, but falling off the cliff is not acceptable. So even if a little bit of hyperglycemia is there, it's okay, but hypoglycemia we should avoid at all costs, because treatment should not be worse than the disease. And that is the feature when you look at basal insulins when compared to, say, premixed insulins or even prandial insulins. And the A1C reduction is also surprisingly very good. And as I mentioned, hypoglycemia, any risk of hypoglycemia, anytime symptomatic, confirmed hypoglycemia, all these are much less. The dark blue color is the premixed analog, and the light gray color is glargine, much less. And if you look at overall hypoglycemia is much less, treatment satisfaction is much less. So basal insulin, ladies and gentlemen, I'm arguing for basal insulin here. It's a simple, flexible regimen. If you want to start insulin, it's ideal because you're titrating it according to the ambient glucose level. There's low risk of hypoglycemia. There is good treatment satisfaction. If you compare to premix, there's more risk of hypoglycemia. There's more weight gain, probably because of the hypoglycemia related snacking, and the dose required of insulin is also higher. Remember, insulin is not an ideal treatment for type 2 diabetes, because insulin means injection, weight gain, hypoglycemia. So the lesser the insulin dose, the better it is. And premix is always associated with a higher insulin dose. So if you see glargine 100 has been the gold standard for basal insulin because it is there for several decades. And now I'd like to show you a case. Now this is a gentleman who's 42 years old. He's on HbA1c is 9.8%. He's on aspart, biphasic aspart, sitagliptin, metformin, glimepiride. And this is his, you can see his HbA1c, this CGM reading. You can see this is not the HbA1c, sorry, this is the EA1c. It is 7.9%, so slightly high. His average glucose is 170. If you take 70 to 180 as a target, you can see post-breakfast and post-lunch values are very high. And he's on a rapid-acting insulin with breakfast, rapid-acting with lunch, and a premix with dinner. And of course, he can afford therapy. So I stopped the biphasic aspart for him. I stopped sulfonylureas, which traditionally should not be given with prandial insulin. I added glargine U300, continued the aspart, and added sitagliptin and metformin. Over time, I added dapagliflozin. And with that, you can see that he had mild GI intolerance to metformin, which is not that uncommon. His could be a familial, also his mother also had metformin intolerance, surprisingly. But I had to stop the metformin. So I had to add a short dose of liraglutide. I continued dapagliflozin, sitagliptin. The aspart doses came down. And you can see the glucose management indicator was 6.4. And though I don't have the time in range values, you can see most of the median values are within range for the continuous glucose monitor. He lost some weight from 104 kilos. His weight came down to 97 kilos. He's doing well with glargine U300, dapagliflozin, sitagliptin. The time in range, as you can see, is pretty good at 95%. There is zero hypoglycemia. And you can see that the aspart is now completely stopped. The average blood glucose level is 132. If you see this 70 to 180 is the range, and you see the median, which reflects intraday variability, is almost a flat line. And I could stop aspart, I could stop liraglutide, I could continue with dapagliflozin, sitagliptin, and he did well with optimization of the insulin regimen. So I'm saying that whenever you have a basal bolus patient or a premix patient, it's keeping on putting weight. You can always, now there are so many oral drugs, you can optimize the oral drugs and try to go back to basal for these patients also. Traditionally, we were told that insulin naive patients do well with premix, and insulin people who are taking insulin, you go for basal bolus. But in today's world, I think with diet, exercise being intensified with multiple oral drugs, I think there is a free way between diet, exercise to oral pills, to insulin, to premix, to basal bolus. And depending on the blood sugar, we can decrease and stop therapies. We can add therapies because patient choice is what matters. Today, if a patient is willing to do diet and exercise on a basal insulin, basal bolus insulin, you can actually come down on the insulin dose and manage with minimum dose of insulin. Patient doesn't want injection, you can give oral drugs, and you can add the oral drugs and reduce the prandial insulin doses and go back. So think of it as diabetes as a very dynamic situation where you can go from one therapy to the other and to the other. Targets are met, keeping the patient centricity in mind. And that is very important in care. Friends, it has been a pleasure discussing this topic with you. Thank you so much for listening to me.
Thank you, Dr. A. Jeevankrishnan, for your lucid presentation on the time-tested molecule that is in our armamentarium for more than 2 decades. Of course, therapy is associated with its simplicity, flexibility, associated with the low risk of hypoglycemia, and above all, the treatment satisfaction. And you have highlighted nicely, very important thing is fixed fasting first. And also the characteristics of an ideal basal insulin, the pharmacokinetic and pharmacodynamic profiles of insulin. Glargine is flat, constant, never peaks at all. So therapy is associated with the low risk of hypoglycemia and the long run with a greater reduction in A1C. Thank you, sir. Now let us move on to next topic, for which I'm happy to invite our Professor A.K. Das to talk on landmark study. He needs no introduction, of course. Thank you. Yes, sir.
Esteemed chairperson and my dear friends, I'm going to speak on a topic which is of great importance, and it's a study on the type 2 diabetes and it is poised to become one of the compendiums of type 2 diabetes, a big data study. I'm going to present a real-world evidence on diabetes management from the landmark study. Dear friends, these are the steering committee members you see here. They're all eminent people, and I've been given the task of coordinating the study. And I must tell you that, the events that occurred in the landmark study are, we started in the 2017, and we also presented the recruitment status and the way the study was designed at the EASD. In 2019, the baseline data was presented at the IDF, and also part of it presented at the ADA. In 2020, we presented the 6-month data, and we have also presented the study design publications was made in the diabetic medicine, and baseline data published for the first year in 2021, and subsequently 2022, we have the second year data, which I'm going to present. And now we are at the third year data, and this will be the closure of the study. Dear friends, to introduce landmark to you, I must mention that it is the first national, large-scale, longitudinal, prospective, observational, real-world study. Dear friends, I'd like you to kindly note that it was a real-world study, as is where is. There was no motivation, there was no instruction, there was no upgrading, no particular product to be prescribed. The RWE, real-world study, pan-India study, I'll show you in a minute. It is quite large scale, so people have called it a big data study. And it's a longitudinal prospective study, but only for 3 years now. We might be extending it further. And only in type 2 diabetes over 3 years. What were the objectives of the study? The objectives were 3. Number 1, to understand the micro and the macrovascular study in a prospective manner. Number 2, the status of glycemic control as is, where is basis in our country, the state of the nation. What is the state of the nation for the glycemic control? And also how long time we take for the treatment adaptation, say changing from the lifestyle to orals, from orals to injectables, etc., in Indian subjects in type 2 diabetics over a follow-up period of 3 years. Dear friends, it's a big data study because we had about 6,236 subjects who were found eligible for this study. It was done about 396 centers across the country. All were type 2 diabetics. The age of diagnosis was above 25 years and below 60 years. And I must add that all these type 2 diabetics were at least more than 2 years of known duration. We cannot the exact onset, more than 2 years of known duration. And they must be at least on the 2 anti-diabetic agents, so that we took diabetics who are moderately severe. To suffice to mention, more than 2 years of duration and 2 anti-diabetic drugs they were on. The data were very simple. I mean, I believe that the greatest truths are simple. So simplistic, we looked at 3 things only. Glycemic trend in these 6,200 patients. There are a few dropouts, I'll come to a minute. The therapy trends, the glycemic trends, the therapy trends, and the complication trends. So very simple analysis. And I must tell you that these posters have been presented primarily in our own meetings in RSSDI. In Chennai, we presented that. 2 papers also have been presented at the ADA. I'll come to that. Now, coming to the participant disposition, I must say that we had in the beginning, the recruited participants were 6,279. And we found that 45 were not eligible according to criteria that I told you just now. And the available population was about 6,234 people. And out of that, there are few people, namely 448, who missed the 2-year visit, but they continued in the study. They couldn't come in time, but they continued in the study. So the available population at the end of 2 years were 5,318, which I'll be describing to you. The inclusion criteria I've already told. The exclusion criteria was any type 1 diabetic patients or secondary diabetic patients, people who are towards the end of life expectancy, and also who are participating in the other studies were not included in the study. And about 448, so 450 people discontinued from the study. The reasons were lost to follow-up, in about 160 patients. Site withdrawal were 156. There are other regions 60. We had voluntary withdrawal 40. Is a purely voluntary study, 44 voluntary withdrawal. We had about 30 CV deaths in 3-year period, and other deaths were about in 11 people. Dear friends, this is the baseline characteristics, the state of the nation as we started the study. You see at the therapy categories in our patients, only oral hypoglycemic agents were in about 74.4%, say about 75%. And OHA plus insulin was in only 24% cases. And the OHAs with non-insulin injectables were negligible, almost nil, 0.7. Only on insulin was 0.4%, and OHA plus insulin per other injector also 0.4. So dear friends, what I want to point out, you might be knowing it already, but is a big data study which has further provided evidence that about 3/4 of the available population was insulin naive at the baseline. They did not use insulin, of which 75% participants received only OHA. If you look at the glycemic status at the baseline, you will find the blue one, about 11.8% people were having the H1C below or at 6.5. About 13% had between 6.5 to 6.9, but majority of the patients were between 7.7 and 9 at about 32% population. And if you look further, you will find that between 8.8 to 9 were about 21%, and above 9%, about 23%. So dear friends, I want to point out that only in about 11.12% people were at 6.5 or below, and another 13-14% people were between 6.5 and 7. Others were grossly uncontrolled and have shown the quantum of uncontrolled in the graph. Dear friends, if you look at the glycemic status or glycemic control at the baseline and at the end of 2 years in these 390 sites all over the country, there was a perceptible drop in the HbA1c. Now, we found the H1C had dropped from 8.1 mean to 7.4 at the end of 2 years. And the data was for the 3,887 patients, 3,900 patients. The fasting plasma glucose also had come down from 142.8, 143 to 129.6. And the PP glucose also had come down from 205 to 187. Therefore, dear friends, there was a significant improvement in all the 3 glycemic parameters, namely H1C, fasting, and postprandial glucose from the baseline to 2 years. Dear friends, there was no compulsion to use any particular drug. You know, there's the Hutton effect of being in a study, one improves. The other two, the doctors seeing these patients, the tenacity of purpose to see that they're uncontrolled and whatever way they wanted to manage it has probably produced this great effect. Dear friend, if you look at the proportion of participants by HbA1c level subgroups at the baseline versus 2 years, we will go from the right-hand side. You see, we had in the beginning about 16.3 people, 3% patients who had H1C more than 9%. It had come down to 5.3%. And between 8 and 9, 8 to 8.9, from 14, it had come down to 10.5. What does it show? It shows that we can do it. With the simple orals or the simple injectables, we can achieve a good control. Now you find the third cartoon, the third parallel bar from the right side, that the people who came into 7 and 8 increased to 16, and those who achieved 6.5, below 7%, was from 11 to 12. So therefore, there is a significant reduction in proportion of patients with H1C who were more than 8 came down, while the proportion of participants significantly increased in the baseline. To make a long story short, we found that the improvement in the H1C was possible, was sizable, and was complementary. So that's a great finding that in about 5,338 patients by investigators. They did it. The investigators could produce great change in the HbA1c parameters. Coming to therapy trends, what did we find? We found that the 75% who are on oral alone, at the end of 2 years, 65% were also on the oral alone. However, there was an increase people who took OADs and added a baseline insulin or some other insulin come in a minute. So OAD plus insulin, what we call in the previous year's language, BITS therapy, bedtime insulin or anytime insulin plus orals, increased from 24 to 33%, a sizable increase. And with OAD alone, with non-insulin injectables were very less, 0.7, 0.6. OAD plus insulin plus non also same. Insulin alone increased marginally from 0.4 to 0.6. So in our country, the acceptance of BITS therapy, 3-4 OADs, we'll be discussing this since morning also, 3 OADs plus insulin is more acceptable, and others were not acceptable. There is a silver line. What is the silver line? That is the reduction in the number of OADs alone group and increase in the OAD plus insulin group. You know, this BITS therapy, to my mind, makes the insulin doses less, makes hypoglycemia less, and also the orals with a submaximal dose can perform better. So this is a good way. This game changer is possible. How is it possible? It was possible because we had multiple investigators meeting without impacting their management issues, but meetings to take stock what's happening, increased knowledge of the investigators, and the tenacity of purpose to control type 2 diabetes. So what we mean to say that monitoring, there are 3 things. What we can improve, that you can measure and take measures to improve that. That possibly has worked. Dear friends, I must also tell you the type of oral anti-diabetic drugs at use at the end of second year. Believe me, 93 to 92% cases were only on the biguanides, and sulfonylureas was about 76-77%. Therefore, the use of biguanides with or without sulfonylurea is the maximal in this population. DP4 inhibitors use is coming up. It was about 48.9 to start with. At the end of the study, 2 years, we have seen today, it's about 61%. The alpha glucose inhibitor use also has shown a rise from 18.6 to 25.2, and SGLT2 inhibitor from 10.5 to 21.3. So if you go by percentage wise, it has doubled from 10 to 20. DP4 has increased from 48 to 61. The thiazolidines, that is the pioglitazone available in our country, has also shown an increase from 11.2 to 14. The meglitinides and the hydroxychloroquine are also used in some population. Therefore, still metformin and sulfonylurea are the prime medications in our country. There's a perceptible practice change in using DPP4 from 48 to 61%, and SGLT2 has doubled from 10 to 20. It has shown a rise. Now, the one great message which came out from this study was that not to go beyond 3 OADs. In this entire study, 10% population were more than 3 OADs. Now, does adding OADs beyond 3 lead to substantial glycemic reduction in real life practice? The answer is no. I'm not presenting the data, but it has been shown in this study that at the end of 2 years, glycemic parameters, HbA1c, FPG, PPG, improved significantly in participants on 3 or less OADs. By adding 1 more OAD, it was not beneficial. Dear friends, the type of injectable glucose-lowering drugs used at the end of second year, we found the basal insulin had increased from 13.5 to 20.6, premix insulin from 11 to 14, and the prandial insulin very minimal from 3.7 to 5.7, and GLP was very, very negligible. So therefore, that wherever appropriate, I'm not telling everybody, wherever appropriate, insulin therapy can be augmented. This depends upon the situational study by the investigator where it is indicated, and appropriately one can take recourse to insulin, and insulin use in our country in the appropriate cases can be made optimal. So we felt at the end of the study now, this insulin inertia has to be addressed. There is a way to make the investigators, the physicians aware where to use it and how to use it. Dear friends, about the complications, I'll be very brief. A total of 57 new microvascular complications were reported in about 55 participants. The most abounding complication was neuropathy, about in 32 cases, followed by nephropathy in about 20 cases, 19 to be exact, and retinopathy in 6 cases. Among the newly reported macrovascular complications, the cardiac complications were high, and we had, as I told you earlier, about 30 macrovascular cardiovascular death. And it was followed by the other large vessel disease or the peripheral vessel disease in about 4 cases. Now, what were the drivers for this complication? Now, I've given the 3 drivers: people who had H1C higher, who had CV risk higher, and BMI higher. It was observed that the microvascular complications were more common in participants who had H1C more than 7 than those who was below 7. Those who were CV risk more compared to CV risk less. And the BMI, when it was higher than 23, the complications were higher. We knew it, but it's the proof of the pudding that it has the drivers. Now, we also had analysis between the metro and the non-metro. To make a long story short, we found the pattern of control in the metros and non-metros were almost similar. Almost similar. Good control was, or whatever the stat of, in 2 years, it was shown that even in the non-metros, there was an improvement in the glycemic parameters like H1C, FPG, and PPG. The only difference we observed was that the microvascular complications were similar metro and non-metro, but the large vessel disease, particularly the cardiac disease and the PVD, was slightly higher non-metro. We are doing a ad hoc analysis. Why it is so, results are not yet known, but this is a fact. Dear friends, the safety of the study was that in the latter 6 months of the 2-year visit, there were some issues of hypoglycemia, 0.3%, and symptomatic were 11, asymptomatic were 2, nocturnal were 4. There was 1 adverse drug reaction, hypoglycemia, at the end of 2 years. I finished, sir. In 2 years, a total of 41 deaths were observed. I have told you about 30 deaths in the CV and the sudden death, and we had MI, stroke, and coronary procedure death 1. So totally another 11 non-related death. So dear friends, the key highlights of the study are the discontinuation rate is low. So Indian type 2 diabetics are looking for us. They're looking for us to be given the proper treatment. Weight and BMI are fairly constant. Neuropathy remains the most commonly reported complications. Biguanides and issue are most commonly prescribed OADs. Basal analogs and the premixed human insulins are the most commonly prescribed injectables. Fasting plasma glucose had shown an improvement. PPG also had shown an improvement, and A1C shown improvement. A1C came down by 0.6, which is good. We could not achieve this in impact study. The PPG came down by 22 and fasting plasma glucose by 15. Patients reaching A1C below 7 increased by 33%. For patients on 3 OADs, A1C fall is less than average. So reduction in the parameters, by 3 is the optimal OADs to be used. So this landmark study provides insight to disease progression and emphasizes the urgent need of controlling risk factors and treatment adjustments, and therapy trends are favorable. People want to upgrade the therapy, take newer drugs, the achievement, and also take insulin where it is appropriately indicated. Thank you very much for a patient hearing. Thank you.
Thank you, Professor A.K. Das, for a very elegant, illustrative, and informative presentation on landmark studies, sir. In fact, it's a pan-India a prospective observational study conducted in real world. That is the type of patients we come across in our day-to-day practice. One of the largest study conducted for a longer duration of years. And very important thing is it has highlighted less than 25% of the patients, they achieved the target A1C at baseline. Over a period of 2 years, there was significant improvement in A1C. More number of patients achieved the targeted A1C over period of 2 years. And you have highlighted nicely the various therapy trends with reference to patient disposition, sir. Thank you very much. Now, let us, do you have time for discussion? Sir, I request Professor Dr. Shashank Joshi, sir, Dr. Unnikrishnan, sir, and Dr. A.K. Das, sir, onto the stage. Let us take the questions from the floor. Now the forum is open for discussion. Yes, Dr. Kannan Idhi, sir. Yes. No, you can. Yes. Yes. No, sir, I will stand. I will stand here, sir.
So it was a wonderful session by all the three eminent speakers. My question to our Dr. Unnikrishnan. See, we learned that both the modern insulins, two basals, that is Degludec and Glagin 300, we have a totally flat profile without any peak. But the same bright trial, if you see on head-to-head comparison of Glagin 300 to Degludec in the new treatment naive patients, well, in the titration period, there was the increase in the incidence of all-time hypoglycemia as well as the nocturnal hypoglycemia. Your take-home points on this.
I agree with your analysis. I think Glargine U300 and Degludec are both equally good and effective insulins. Studies this way and that way have shown differences. In fact, there was another study called the Conclude trial, and when the trial was presented, on the stage they said that between Glargine U300 and Degludec, it is difficult to conclude anything conclusively from the Conclude trial because both the similarities are more than the differences. At that point, the advantage comes to the cost, and there Glargine U300 is a little more inexpensive, and that may be the slight, edge that it may have. But otherwise, both are great insulins.
Batman, you like to add or you want me to? Let's fight here.
So two things. One is that in titration phase, clearly nocturnal hypoglycemia is less with U300 largely. Cost is lower, as Unni said. So clearly there are those advantages.
How much is Glargine 300?
So it's lower than the Degludec cost.
How much is it?
So that's
don't worry.
we are not here to discuss the economics.
We
We
know.
will be discussing the science of it. So from science standpoint, it definitely has advantages. There are two other advantages which I wanted to highlight beyond only. The BRIGHT sub-study, which was presented a year later, showed that in the elderly population and in the renal population, there was lower hypoglycemia. Now, the vulnerability of hypoglycemia in senior citizens, particularly above 70, 80, and 90, and those were the cohorts analyzed at the ADA presented 1 year after the BRIGHT was presented, clearly they showed lower hypoglycemia. Similarly, in the renal cases where eGFR was below 30, 15, 30, 45, and 60, the U300 Glargine had lower hypoglycemia. The third advantage which was there with U300 Glargine compared to Degludec is that in the type 1 population, when the CLAMP studies were done, again, in the titration phase, the advantage was clear-cut. But in the maintenance phase, it was there. The only challenge with Conclude was it was interrupted in between because they had a poor glucose meter reading, and therefore it had to be, interspersed that so that the validity of the RCT base of that Conclude is skeptical. But head-to-head, three things matter. Access, affordability is not an issue. Then head-to-head, if you look at from a pure scientific standpoint, U300, then Degludec, then of course U100 Glargine, and then NPH, in that order of pecking order for PKPD from a science standpoint.
Biosimilar. The lowest is biosimilar.
Interchangeable. See, Glargine U300 and U100, there is interchangeability available.
Mylan has come out with the
You're talking biosimilar.
That is,
That is economics. We are not, see, science is one and economics is something else. So economically, we are not here to discuss economics. We are here to discuss science.
Okay, good. Let us talk about the politics of this basal insulin, okay?
No, that's
See,
not the science.
Listen,
We are not here to discuss politics
The
and
incremental improvement, okay? Your innovation is not innovation, it is incremental improvement, may benefit type 1 benefits in Scandinavia. Okay, you said that type 1. And you are imposing this with a huge funding. Okay, you know about, see, everybody, do you do private practice with fee for service or just like that? The question is everlasting patent, blatant abuse of patent by your company. Okay, every day in US, 15 million.
so
22.
we don't here, we are not here to represent any
So
company
let
and
us,
any
let us,
house.
let us
We
sign,
are here-
let
we
us
are
sign
here-
an agreement for what is that, this waiver of this patent,
Mm.
everybody will
No,
benefit.
we are not here to discuss politics.
You are here to market. I am
No, we
here
are not here to
market
discuss market
people.
also. I think you are,
Okay?
you are
No,
just,
no.
you are here to
Patent
disrupt.
Patent abuse.
So you are,
It's a
you are-
human rights issue. Okay.
you can.
What is the
as
price?
much-
You don't know the price.
Sir, can I ask questions, sir?
What?
The
patent.
chairperson permit?
You can shout as much as you want.
Yes, sir. Can
Your
I ask a
irritation, no,
question?
no, let him talk.
Sir, sir,
Let him talk. Let him talk. His irritation quotient and his loudness quotient is very high, which we compliment, put our hands together for him, because you are really having a high IQ and a high irritation quotient. No, your IQ is irritation quotient. So you are irritated. Yeah.
Sir,
But this, we are here for practice of science. This is not a scientific question. Dr. Karunanidhi asked a science question, not a political question, period. Ask a science question. I can also shout. Stop your shout. Stop your crap.
Sir, can I
Talk
ask-
science. Don't talk nonsense. Talk science.
Sir.
Talk science. Talk science. Talk science. Talk science.
Sir,
Talk science.
sir, please.
Talk science. Wait. Talk science. Talk science.
Sir.
Talk science. Talk science.
Sir, what is this? We are here
So
to-
I
we
think
are here to
Dr.
discuss
Mathur
science.
has a
This is
question.
scientific
You have a
forum.
question? Yeah, please ask your question.
Yeah, please.
Yeah, I have a question for
Yeah.
Professor.
Next question.
I question for Professor
Let's
Das.
discuss.
Sir. Sir, can you
Yeah,
allow me
yes,
question, sir?
please.
Yeah, sir, I have a question for Professor Das. Sir, I have a question for Professor Das. Sir, landmark is a landmark event in the history of diabetes in India. I think excellent effort from our country to have our own data and then change the practice accordingly. Sir, my question is, sir, did you analyze your data in terms of use of any particular combination of drugs, and incidence of micromuscular disease diagnosis in that duration?
Yeah, I think,
Dr. Sir could understand my question, sir.
yeah, Professor Sandeep has asked a very important question. You know, Dr. Sandeep is one of the original investigators of the country. His work in the brown fat and currently his work on the genomics has made, give a big hand for him. Sandeep Mathur is one of the most upcoming and he'll be present. So I would like to answer his question is very pertinent. Did we analyze the data on the combination therapy? Sandeep, this is ad hoc presentation. We have not looked into, but we now encourage combinations for two reasons. Number one, that as you know, we have a FDC market. It is convenient, it is compliant increases and the cost comes down. Number two, keeping in mind that we want to produce early control, say first year control, whatever, we promote this combination because today monotherapy is probably for a very short time or out of vogue. So I'll give you the data after the analysis is done about the combination.
Sir, can I have one more question
Yes,
to you,
please.
sir? Actually, I am wondering, could we have a pharmacogenomic study in our country? And we know you are the father of pharmacogenomics in our country. You started initial work. Sir, inter-individual variability in response to any drug when
Yeah,
we
I get your
research.
point.
So if it is there, then we need to go for pharmacogenomics because I reviewed lot of pharmacogenomic data.
Yeah.
This is more related to, I will be happy if Shashank can answer this question.
So actually, Dr. Das has done work on that. He was the first person to do work on OCT organic in metformin.
Yes.
And no difference was found except for metformin intolerance. That was a Puducherry study with French collaboration. And we have done some work in gliptins. So you talk about your metformin data and then I can talk.
Yeah, I think the pharmacogenomics or the precision medicine is one of the in thing today. As you rightly said, there is a difference in the pattern of response. As far as metformin was concerned, we did not find OCT1, OCT2, two genes as you have read that paper, we looked into. There was not much reference in the non-responders, but there was difference in the people who did not tolerate it. Now, we have not extended the study to other pharmacogenomics. I think I know about your application. Sandeep has applied for a huge grant for looking into the pharmacogenomics of most of the anti-diabetic drugs.
Yeah.
And maybe that will pave the way.
Sir, because the technology of genomic, diagnosis or genomic data generation has become robust now.
Yeah.
Now, we cannot only have whole genome sequencing in one run. We can have whole proteome analysis, whole metabolome analysis, whole transcriptome analysis, or RNA profiling. So your study initially, actually Flippy Friggle told me about this work.
Yeah.
Because I was in Imperial College that
Yeah.
time. So that time technology looking for one gene.
Was there.
So our problem was the genomic technology, not with the
Exactly.
drug. My question is inter-individual variability, because this data need to be analyzed. Suppose there is a wide inter-individual variation, only then we can go for actually robust genomic.
Exactly. I
testing.
think-
That is my point, sir.
Yeah, I think
If
out of-
variability is very high, then it is worth pursuing that.
Yeah.
If variability is not much, then not pursuing.
I get your point. I think wonderful point Sandeep has made. He says, look into your data of this 5,000 patients
Yeah.
and see in whom, which oral drug did produce result.
Yeah.
At least minimal or at least moderate to
Yes.
expected. If it is not producing results,
Yeah.
you must identify those cases
Yeah.
for a genomic analysis.
For
I
genomic,
think
that is the my
good-
question.
So
Good,
one-
very good suggestion.
So one more thing,
So what
Sandeep, I want to highlight that the intra-individual variability of any oral drug preparation and insulin is 30%, 30, which means the response to a pharmaceutical compound is 30%. Inter-individual, that means between two individuals, is as high as 46% for insulin and 32% for drugs. So this is not something which the industry does. And this is for governmental sponsored work to do so that we can minimize that, because the response of human beings to drugs and responders and non-responders is not very clearly recognized. In the good old days, if you read pharmaceutical and pharmacology books like Goodman Gilman, the old edition, they used to have a coefficient of variation.
Yes.
And the old CV was highest for chloropropamide, and which is why it was banned. Then the CV was high for glibenclamide, which is why it was withdrawn. We still have it in India. Then it became lower for newer drugs like a gliclazide or a glamipiride. So that was based on all the inter as well as intra-individual variability. Same thing is we use subcutaneous tissue space as a reservoir for insulin. And the newer insulins which are being so-called innovated are trying to reduce that inter and intra-individual coefficient of variation. Now we don't highlight when we talk to this, any industry house, we don't ask them, just like for a glucose meter, we should ask them for a YSI graph, we should ask for error grade analysis. We don't ask what is the inter-individual variability, what is the intra-individual variability, what is your coefficient of variability, what is your hyperbole, for response of drug. We don't ask them these questions, and these questions are often hidden.
I
Yeah,
just
you're
tell you
very
that
right.
we have the clinical pro forma seats of all these 5,000 patients.
Yeah.
And we are having a meeting following 19th of February. And
Okay.
we will definitely look into the data because that will identify the population in
Yes,
whom
sir.
the pharmacogenomics with
Can-
a less funding,
Yeah.
with less expense, we can get results.
Yeah, we can actually
I get your
join with your group and do analyze
Yeah, yeah.
this. And then we will say, yes, we
We
need
will-
farming.
I'll certainly get back to you something.
Thank you very much, sir.
Thank you very much, sir.
Thank you, Shashank, for your comment. Thank you.
Yes,
very
sir.
much.
I thank all the speakers for the nice presentation. I also thank all our delegates for their wonderful interaction with us. And I thank the organizers for giving me an opportunity to chair this session. Also thank Sanofi for accepting me as a chairperson for this particular topic. Thank you, sir.
So I sincerely thank the speakers and the chairperson for taking this session wonderfully. Moving on to the next session. So this session will be chaired by Dr. N. Kannan and Dr. Rajendran. Thank you.
Uh, I thank Professor Krishna sir for giving this great opportunity. Now we have an important keynote lecture. We have two keynote lectures, which is very, very essential for our clinical practice. The first lecture will be, see, dear friends, in our recently passed away epic on 2023, our own colleague presented an important paper on the 10 commandments of type 2 diabetes management. Among these, the healthy lifestyle and the healthy better habits of the patient is very, very important for the appropriate type 2 diabetes management. Professor Shashank Joshi will be addressing in all the conferences as a concluding message of his own Veda mantra of the patient's effective habits. For this, now we have the eminent, our dynamic speaker, our Padma Shri, my mentor, my Guru Anna, Professor Shashank Joshi, to enlighten on these highly effective habits of people with diabetes. Over to you, sir.
Thank you so much, Professor Kannan. And I must thank Krishna for having this talk here. It's a very different talk. I have to talk on highly effective habits of people with diabetes. So it has no conflict of interest for this talk, except that my good friend Krishna is my only conflict of interest here. And with Krishna, of course, is Arvind, Sanjay, and Prasanna Kumar. So this is one talk without any duality or conflict of interest. So we all are all here to listen. What we listen, we learn. What we learn, we adapt. And Carl Jung said that you are what you do and not what you say you will do. So that's really the key of this. So what I'm going to talk is like, for the first time, you see a lot of emphasis on lifestyle in the ADA-ESD consensus and lifestyle issues. Then I'm going to talk a little bit on digital diabetes care because it's really a part of habits. And to have healthy habits inculcated in people living with diabetes is standard of care. And then, of course, my mantras on diabetes care and prevention. So the whole focus of the joint ADA-ESD's consensus on management of hyperglycemia and type 2 diabetes was all pharmaceutical. And to prevent complications appeared to be their buzzword. But there was also a second tenet to it, which was optimizing quality of life when it was presented on Friday, September 23rd at Stockholm. And, this whole prevention of complications had this quadrant, glycemic management, cardiorenal protection, weight management, cardiovascular risk factor management. But I'm not going to talk on that. I'm going to talk on habits a person living with diabetes must inculcate, the right habits. And actually in that consensus, there is another slide kit, which people don't talk. And I'm going to talk on that slide kit, which is putting the person with diabetes at the center of our universe. We are here because people living with diabetes are very germane to us. And clearly we can see that the decision cycle of a person-centric glycemic management is to assess the key phenotypic characteristics, then have specific factors which impact the choice of treatment, then use and make the person living with diabetes your partner in care, shared decision making. That's the key today. Because unless and until you do not make the person living with diabetes a partner in your care, you really don't get going and cracking on it. And then you need to agree to that management plan, implement that plan, keep reviewing and support that plan. And inertia is a huge problem. We as healthcare providers have a lot of inertia or barriers. We know that clinical inertia is failure of healthcare providers to initiate or intensify therapy. And there are a lot of reasons for that. But the first point which got inserted in the ADA-ESD consensus was really the 5 S's, which need maximum support from each one of you in the audience here. And the 5 S's are: sitting is the next smoking, break up your prolonged sitting, keep sweating it out, strengthen your muscles, do a lot of steps, and sleep well. And I'm going to talk on all these 5 S's because if a person living with diabetes needs to have good, effective, healthy habits, the 5 S's are very key. Sitting is the next smoking, keep doing brisk walk and don't sit all the time, sweat it out, do a lot of steps, try to make your 6, 8, 10,000 steps. 6,000 are good enough. There's good data to suggest that. And then, of course, strengthen your muscles. You need 60 minutes. Dr. Mishra is in the audience. I just saw him walking in. He's published a consensus long time back on Indian guidelines on on exercise and physical activities, and sleep is the next buzzword. So the first point is sitting. Break up prolonged sitting. Every 30 minutes you should limit sitting and have short bouts of slow walking or simple resistance exercises. That's the first habit we must inculcate in every person living with diabetes on planet Earth. Try to tell them that sitting is the next smoking. Chair is not good. Do not be sedentary. Try to break your prolonged sitting beyond 30 minutes with a short bout of a short walk. Sweat it out. Encourage 150 minutes of moderate to intense physical activity with large muscle groups and rhythmic in nature. They have recognized that. ADESD has very clearly recognized that. Or 75 minutes per week, vigorous intensive activity for at least 3 days a week and with no more than 2 consecutive days of inactivity. So don't be inactive for more than 2 days. So the second habit which is encouraged is try to do moderate or vigorous exercise and do not have a activity break of more than 2 consecutive days, and supplement with 2 or 3 resistant flexibility and or balance sessions. I live on the gym floor and I saw very few people on the gym floor today. Okay, and that's really recognizable and important that we need to do a physical activity all the time. The third part, which is highlighted in this very much guidance of ADESD to inculcate right habits, is identify the frail phenotype. We as Indians are sarcopenic, we are frail, and we need to ensure that the physical frailty at an earlier age needs to be broken. And therefore, simple functional exercises in middle age are very crucial. So try to build that little muscle, try to sweat it out. Steps. Excellent data published worldwide shows that even if you do 500 steps per day, it is associated with 2 to 9% decreased risk in cardiovascular morbidity and all-cause mortality. And this is very, very compelling. You can use this in your day-to-day practice. 5 to 6 minutes of brisk walk. I recognize 5 to 6 minutes of brisk intensity walk per day equates 4 years of greater life expectancy. So you can actually add 4 years to life by just 5 to 6 minutes of brisk intensive walk. So step, and step, just do 500 steps per day, decrease the cardiovascular mortality and all-cause mortality by 2 to 9%, and 5 to 6 minutes of brisk intensity walk per day equates 4 years of greater life expectancy. Strengthen. The second last S is strengthen. Resistance exercise. Any activity which uses the person's own body weight or works against resistance improves insulin sensitivity. And for the first time, they have recognized Yoga and Tai Chi. Surya Namaskar, Kapal Bhati, Uthak Baitak, all have been recognized in the ADESD consensus. It's very rare to find them recognizing some of our ancient wisdom, but strengthening muscles is the key. Resistance exercise is the key, and there are encompasses of flexibility and balance in it. And the final S is sleep. The final S is sleep. Krishna has missed the first 4 S's. Okay. But I love his veshti and I wish I had one so I could wear one. Okay, sleep is necessary. You know why? Because our cortical surface of the brain has tissue perfusion by CSF. If you are awake all the time, and we have these bright lights which are very bad for health. If you are awake all the time, your interstitial space is reduced, your CSF flow is reduced, and negative metabolites accumulate. And therefore, good 7 hours of sleep is crucial for good health, because sleep is the housekeeper of the brain, what Underwood said in Science long time back. And if you restrict sleep, the human transcriptome gets restricted. And I borrowed a slide from Krishna. Krishna is our Krishna Sheshadri, not Lord Krishna, but I equate him with Lord Krishna. Okay. And this is from our scriptures, Aruna Prastham. The course of time is understood through changes brought about by the rays of sun. So it is a sleep-wake cycle and the light and life which our diabetics need to inculcate. There's a whole new science of melatonin today, which is called as functional splanknology. You must, if the internet is full of all this, blue blocker glasses, rehabilitation protocols, the chemical signal for darkness is called melatonin, which is our biological clock regulator. And you need to have natural source of melatonin. You don't need to take melatonin pharmaceutically. You just can have some 70% plus dark chocolate or cherries and cocoa. So that's a good source to eat. Okay. You could have a banana, which people in South India consume, or some ginger, or some wheats, oats, corn, rice, barley. You could have some peanut butter. You could have walnuts, almonds, cashews, pistachios. You could have fruits, veggies, spices, and herbs, and green tea. And all of them can lead to excellent things. Also, when you sleep at night, remember, if you get light emitted by television or telephone, it prevents the pineal gland to secrete melatonin. It shuts off the pineal production of melatonin. So when you are sleeping, shut off your mobile phone, shut off your television screen. Don't sleep in front of your television screen. It's not healthy. And the best night light is not blue light, it's red light. Because red light has the least effect on secretion of melatonin. And that's the best color for bedroom lighting. So red light is another take-home message. Also, avoid coffee, tea, and colas at night because they really shut off the melatonin. And have an early light dinner because we know that that promotes aging and insomnia. So sleep hygiene is very important. I'm only, as I said, I have to talk of habits, and in habits, sleep hygienes have do's and don'ts. Try to sleep for 6 hours at a stretch. Maintain a regular wake and sleep time. Wear loose, comfortable clothing. Try to take a bath. Remember that the rise and the fall of temperature promotes drowsiness. Take your medications on time, particularly for people living with diabetes. Try to have a cool, calm, dark environment. Try to have a good pre-sleep routine and listen to some nice music. Don't enforce sleep. Avoid consumption of medication and alcohol and coffee. Do not have these red lights. Don't use mobile phones, electronic devices, games and laptops. Don't have junk food and heavy dinner. So those are the don'ts for a good sleep. And then yoga is good. Balasana, Uttarasana, winding down twist, rockabye, the restorative yoga with poses on the leg. Very easy to do, not difficult at all. So sleep also sees a recognition in the ADHD guidance. As I said, these 5 S's are not recognized when we speak, and I'm happy Krishna gave me this opportunity to speak with all of you all and engage with all of you all on the lifestyle habits which people living with diabetes to encourage. And this is recognized now. That quantity of sleep, don't sleep more than 8 hours, don't sleep less than 6 hours. 7 hours is optimal. Ma'am, Yvonne Couture from University of Chicago has done some elegant, she's the sleep lady of the world. She might get a Nobel Prize one day. Based on her research, if you sleep for 7 hours, that's the optimal sleep time. But don't sleep less than 5 hours, don't sleep more than 10 hours. The quality of sleep is important. Irregular sleep will have poor glycemic results and will increase insomnia in people with diabetes, and recognize obstructive sleep apnea and restless leg syndrome. A lot of people have restless leg syndrome. It can be treated. And finally, the chronotype. The evening chronotype, the night owls go to bed late, get up late, is bad for diabetes. The morning chronotype, early bird, go to bed early, get up early, which is why probably South India has an early chronotype, but they still have high diabetes because their other habits may not be up to the mark. But that's a good chronotype. So it's important that chronotype is important, quality of sleep is important, and the duration of sleep is important. So sleep, also the sleep science has advanced, and we need to do it correctly. Unfortunately, instead of focusing on all these 5 S's, we are fixated in all this other things in life. You see this every day. We're only talking of glucose, weight, cardiovascular risk, and cardiorenal risk, and all the pharmaceuticals around it. We need to grow beyond that. We need that. I'm not saying we don't need drugs and we don't need insulin, but lifestyle is also important. Habits die hard. Habits need to change. Behavior change needs to occur, and we need to encourage behavior change. So we don't become just glucose-centric and medication-centric, grow beyond that. And this is what these slides are there. But we don't talk on these slides. Integrated care has been recognized by ADHD now. Acknowledge the lifelong and the evolving nature of type 2 diabetes. Acknowledge that. Identify and coordinate with the team, because we may not have time to engage with our people living with diabetes. Engage a team. Get a dialogue with them. Know your local resources. If you are in Tamil Nadu, Tamil. If you are in Kerala, Malayalam. If you are in, Maharashtra, Marathi. If you are in Delhi, Hindi. But engage your local resources. Language matters in diabetes care. Language matters. It's important to connect, important to develop rapport. And that's an important habit to have, because then people with diabetes are happier, healthier, and live longer. Consider each human living with diabetes for that individual, specific context, specific risks, and specific preferences. Again, it's all highlighted in the ADHD guidelines. We don't talk on these slides. And then look at the healthcare system, the inequity of healthcare, but be evidence-based in interventions. Intervention can be lifestyle. It could be as simple as the 5 S's. It could be as complex as a complex GLP-1 insulin and a SGLT2 regimen. But it's important to recognize that we need to be equitable in our approach. Address the social determinants of health for every individual living with diabetes, particularly if they are not at goal. If somebody is in rural Tamil Nadu, not able to afford and access a CGM and gets a regular insulin with some regular SU with metformin, but gets an A1C 7% without hypoglycemia with some education, that's also equally great. It's not to be condemned. And that's important to recognize the social determinants of health and incorporate comorbidities. The ABCDEF approach is equally important. A for A1C, B for blood pressure, C for cholesterol, D for diet, E for exercise, F for feed. It's very important to recognize that's recognized there. And encourage diabetes self-management, education and support, and local resources again come up, and healthcare team, and be holistic in the approach. So healthy behavior is my talk, and facilitating healthy behavior is very important, particularly when you're managing weight. And we need to reevaluate, monitor glucose, monitor weight, track physical activity for a health behavioral change, because they become very good tools. And when we are able to educate our patients, they do autocorrection. See the advantage CGM has given us now. Our patients are able to understand that if they have 3 idlis and less sambar, then their glucose goes up. If they have 1.5 idli with 1.5 vati of sambar or a bowl of sambar, their glucose comes down. So they are able to do their autocorrection on their own when they recognize, and we need to spend time on education, education, and education. We have choices of medications. We have comorbidities and obesity. We have personal profiles. We have adverse event monitoring, and we have organ protective medications. Be mindful of all of them when you choose them, but don't forget insulin. Insulin still, don't delay and defer. There's a popular myth, and people go from doctors to doctors, they change their doctors. But if person needs insulin, person is catabolic, person is symptomatic, person needs insulin, don't hesitate to give insulin. So the overarching philosophy in the habit talk, which I want to tell you, is make it work, make it work, and make it work. Because we are here for our people living with diabetes. And India is very unique. We are different. We have different clinical phenotypes. We have different manifestations. Cost and complications, access and adherence are equally important as much as what you may say. And the main thing is one size doesn't fit all. Yes, we need good glycemic control. We need early intervention. Yes, we need to have patient safety, but we need individualized approach. An approach has to be individualized, and technology is coming to our aid. Clearly, we need, what is innovation in healthcare? Technology is coming to our support. More value, better outcome, greater convenience, better access and simplicity at a lesser cost, lesser complexity, less time by patient and provider. That's the key. We really need, today mobile phones have revolutionized our life, smartphones have revolutionized life, because we are able to spend less time, make things simple and cheap and effective and economical, and add value outcomes as well. We have moved gears from A1C to reduction of hypoglycemia. We have used smartphone apps and AI. We have improved quality of life, but the moving target from A1C has changed to time in range for the highs, the lows, and we clearly recognize artificial intelligence has arrived. And it's there on our mobile phone. You Google search, a trip from Chennai to Mumbai, and after another half an hour, 1 hour, you will keep on getting pop-ups because your smartphone recognized you are making this search, and it keeps on recognizing that. Similarly, AI does the same thing. And this has been used every day We use twin technologies. We know how to understand metabolism, but digital diabetes care has arrived. You know, in digital diabetes care, we have hybrid devices and we can use AI to make a difference. My final points are all habit points. People living with diabetes still have stigma in India and across the world. So we need to use psychological tricks. We need to empower them. You know, no person living with diabetes should feel stigmatized or discriminated. And that's an IDF mandate, that's a global mandate, that's a personal mandate, that's a local mandate. If somebody insults you, pause for a second, look at them and say, are you okay? If you think someone is lying, look in their eyes and say, don't say anything. If you are in an argument, keep your voice calm. It will give an impression that you are winning the argument. And good posture always increases confidence. So you need to do all that. A lot of people have egos, you know. So we need to move from limited thinking to unlimited thinking. We need to seek safety to calculated risk. We are into an unpredictable world. We saw it in COVID times. And we don't need to be adventurous. We need to seek stability, but we need to change. We seek comfort, but we need to grow. We need to see what is known, but we also need to embrace the unknown. And we need to have desires, but we need to sacrifice vices. And everything is not necessarily bad. You know, some things are good too. So we need to change our mindset. And our people living with diabetes also need to change their mindset. We need to kill our egos. We need to value love. We need to smile. We need to ignore gossip. We need to be successful. We need to distance jealousy. We need to acquire a lot of knowledge. You have acquired that here. And we need to trust confidence. So there are life hacks. If you feel uninspired, go for a walk. If you are in a bad mood, work out. If you're thinking too much, meditate. If you're tired, sleep for 7 to 8 hours. If you're sad, listen to music. If your focus is low, cut social media. If you're bored, socialize. Final mind hack, keep open mind, keep learning new things. Take one small step at a time. Think about the words you say. Stay positive, practice gratitude. Do something which makes you happy. Learn to take criticism constructively. But do digital detox. We are in an intoxicated world. I'm going to take a minute more. Okay. Sleep well and sleep on time. Eat less, eat on time, eat in the morning, eat slowly and eat right. Okay. Sleep well and smile again. Please learn digital hygiene. All of us we need to do 1 hour to 2 hours of digital detox every day. That means no smartphone, no mobile phone, no television, no TV camera, no computer screen. And one more digital tip I want to give you in digital hygiene. Nowadays, you will see in every guideline digital hygiene coming up. This habit is damaging your energy. If you scroll your mobile phone, first thing you get up in the morning, you will spoil your day. There's data. There are 19 papers published last month that if you scroll your mobile phones in the first hour of the day, it's an incredible way to kill the momentum of your day. So please, when you get up, don't look at your mobile phone for 1 hour because it will flood your brain with cortisol, unearned dopamine in the morning, and it will leave you sluggish and brain clogged. Don't look at your phone for the first hour of the day and tell me the difference after 15 days. And there's science and data around it. And this is taught to me by a person living with diabetes, digital hygiene. My mantra is very simple. We are here to learn good habits. Habits die hard. So I think my tips to people living with diabetes are eat slowly, eat less, eat on time, and eat right. Do a lot of movement, do physical activity. If you can encourage all the 5 S's, great. If you can do yoga, sleep well, smile, that's equally great. And be committed to health and happiness. And again, I encourage you to have some digital detox and digital hygiene. Thank you, Krishna, for this nice talk you gave me. I'm grateful to you. And I hope you have learned some tips of wisdom and pearls of wisdom from habits because we are often ignoring them. And we are so obsessed with treating goals, but habits are the ones which make a difference in people's lives. Thank you so much.
Thank you. Thank you very much, sir, for the wonderful and excellent talk with standing ovation. You are going to great interblend between the hormone and sympathetic activity by the ways of 5 years, and also the wonderful scientific word we enjoy, sir. The brain, housekeeping regarding with the sleep. Thank you very much, sir. We enlightened, sir. Thank you. Thank you very much, sir. Thank you. We have the question session at the end of the session, sir. Dear friends, now we move on to the other important topic, which is on hypothyroidism. We know that in the classification, we enjoyed about the primary hypothyroidism. In the primary, we have at the level of both symptomatic as well as the asymptomatic as a form of suboptimal. of subclinical. In the secondary hypothyroidism, you know, at the level of hypothalamus and the level of pituitary. But we have the unique topic, what is so-called as tissue hypothyroidism. That means cellular hypothyroidism, whether we want to deal with that. If it's so, how we will manage it? For this, we have the eminent speaker, Professor Dr. Krishnan from Chalaran's Diabetes Institute, Pune. Welcome you, sir.
Thank you. Thank you. Thank you, Chairperson. And it's a pleasure to be here. And I'm going to talk about tissue hypothyroidism, how to identify it and how to treat it. So at the end of this presentation, you should be able to understand the role of T3 in human health, look at the conversion of T4 to T3 in tissues, and whether it has implications for clinical care. So I'll start with two MCQs, which is a wrong statement about deiodinase type 2. It's present in the brain, muscle, heart, thyroid of humans. It catalyzes conversion of T4 to T3, is involved in consumptive hypothyroidism, and 4, it removes the iodine atom from the tyrosyl ring. Second question, combination of T3 and T4 has a selected role in practice. People with deiodinase gene polymorphism may benefit, may be considered according to the European Thyroid Association. All of the above are correct. So let's look at a case. Now, this is a 60-year-old lady who has hypothyroidism. She has no comorbidities, but occasionally feels tired and has constipation, fatigue. Now, if you look at the T3, it's 61 and the T4 is 9, the TSH is 4. So what's going on here? Is the tiredness because of the relatively lowish T3? Is it because of hypothyroidism at all? Because as they say, the symptoms of hypothyroidism are like the symptoms of life. Everybody after a certain age puts on weight, has dyslipidemia, so on and so forth. But if you see the thyroid function, it's almost normal. Well, this patient was put on T3 and the dose calculation was done like this. The T3 dose was, she was on 100 of T4, so T4 by 20 is equal to 5 micrograms, and T4 dose was reduced from 100 to 3 into 5, so 85. So she was given 87.5 micrograms of T4. So the 100 microgram of levothyroxine was reduced to 87.5, and the T3 was given at the dose of 5. See what happened. After 6 weeks, you see the T3 has shot up. The T4 is remaining about the same, but see the TSH has really gone down. So her symptoms didn't improve very much and she didn't feel better. But at the same time, we have to know about why this was done by the treating doctor. So what is tissue hypothyroidism? Tissue hypothyroidism is a peripheral or cell-mediated hypothyroidism, a condition where the thyroid gland produces enough hormones, T4 and T3, but the cells and tissues in the body are not able to utilize these hormones effectively. This can happen due to a variety of reasons, such as deficiency of nutrients required for the conversion of T4 to T3, or a dysfunction of the cell's ability to transport or respond to the thyroid hormones. It's at present, it's an evolving entity. So watch this space. What I may saying now may change in future. This is a paper by Dr. Kalra who asks, should we unsympathetically dismiss all the persistent symptoms such as weight gain or asthenia and hypothyroidism, or should we try to find reasons for them? He also argues, should we treat patients only according to their TSH levels, which actually represents the health of their hypothalamo-pituitary axis? TSH is produced from the pituitary, or other symptoms which represent the health of the whole body. So to understand that, let's look at what happens in the nucleus. In the nucleus, the story is all about T3. Now, in contrast to the steroid receptor, the thyroid receptors remain in the nucleus even in the unliganded, in the inactive state. The thyroid receptors, when the thyroid hormone binds to the thyroid hormone responsive element, or TRE, in the enhancer cells of the target genes along with the co-repressor. So you can see the thyroid hormone receptor and the thyroid hormone and the T3 binding to the thyroid hormone receptor. And there's a co-repressor which gets removed and the co-activator that gets recruited. And that binds to the thyroid hormone response elements on the DNA. Remember, this is all T3. T4 gets converted to T3 or T3 directly enters, and in the tissues, the thyroid hormone response elements leads to transcription, mRNA, and protein synthesis. So this is how the thyroid hormone works. It has to work. It's a nuclear action. So it acts mainly on the DNA, and it's all T3 when you look at within the cell. So the whole concept of tissue hypothyroidism is built around T3. Now, the important thing to remember is that T4 therapy does not alone guarantee euthyroidism. If you look at the study of 181 people who had thyroidectomies and we given T4 treatment, about 7.2 had a higher free T4. 15.2 had a lower free T3. So keeping on giving T4 will not solve the situation because the T3 remains low, and therefore the T4-T3 ratio, the T3-T4 ratio remains slightly low. What is happening here? It's interesting because when you do a thyroidectomy, the patient's T3 is coming only from conversion of T4 to T3. But remember, the thyroid gland also makes T3. That is gone away. So here the patient is only getting T4, and the T4 has to be converted to T3. The thyroidal secretion of T3 is not there. And therefore, could the tissues be responsive? So if you look at the pituitary TSH is a good indicator of free T4. Small changes in free T4 make a massive change in TSH. It's a log linear relationship. Small changes in T4, huge changes. But if you look at T3, the story is a little different. These are, post-thyroidectomy patients. And this shaded area represents the post-operative TSH levels. This looks at the post-operative TSH levels between 0.3 to 0.3. Now, if you see a post-operative free T3 level equivalent to the preoperative level, which was achieved when the TSH was around 0.1. In other words, this study showed that moderate, suppressive, you have to really suppress the TSH for them to achieve. So the TSH has to be suppressed to at least 0.1 to make sure that the free T3 is normal and unchanging. And this is, of course, for people who had before their thyroidectomy, what was the TSH, and after the thyroidectomy. So now you have two groups, not in this study, but in patients. One group has got a normal TSH, but a slightly low T3. And the other group has got free T3 levels equivalent to their preoperative free T3 levels, and the TSH is suppressed. So do you want a T3, T4 normal and TSH suppressed? Because you need to give, that's where T3 acts. Or do you want to get a T4 normal, TSH normal, and T3 slightly low? Which one is better? And that brings us to a conclusion that a normal TSH may not guarantee normal T3. You'll have to probably suppress the TSH, and the suppressed TSH might do that. So if the TSH is, if the TSH is below 0.03, then the T3 levels are going to be usually high. But if the TSH is 0.03 to 0.3, the T3 is going to be normal. And where the TSH is above 0.3, the T3 is going to be low. So that is an important thing to remember. If you want to normalize the T3, you will have to keep the TSH 0.03 to 0.3. But are we willing to do that? I'm not willing to do that for my patients, frankly. So that is something to, but the answer is that we require more and more research into this field. So therefore, there are some problems here. I said that the TSH is not a good indicator of hypothyroidism. Why is that? Because the pituitary deiodinase is very stable, but the peripheral deiodinase is not stable. What does deiodinase 2 do? Converts T4 to T3. In the pituitary, the conversion is pretty good. So if you give a T4 tablet, the pituitary immediately knows there is T4 and it suppresses a TSH. But this conversion is not very good in the periphery. That conversion doesn't take place so well. And therefore, the peripheral tissues are not getting enough T3, but the brain is getting enough T3. And therefore, the brain tells you TSH is normal, but in the periphery, there is tissue hypothyroidism. Again, this is an evolving science and it's a theory. And therefore, the LT4 is good and the LT3 is good in the pituitary. Even if you give the same LT4, the same levothyroxine is less LT3 in the pituitary. That is why you may need to give more T4 to suppress the TSH and keep the T3 normal, something which we are not willing to do. So that brings us to why we should look at this T3 therapy. So as I said, the T4 in our blood comes from the thyroid gland, and that T4 gets converted to T3. But remember, the T3 is also produced directly by the thyroid gland. Let's look at some more numbers. What is the argument for giving T3? Many tissues say they want more T3, more T3, more T3. The thyroid gland makes T4, which gets converted to T3. Sometimes the thyroid gland directly makes T3 also, and that gives the tissues their T3. Now, the peripheral conversion of T4 to T3 is not very great. So that's why you get an increased T4-T3 ratio. If you give a patient just levothyroxine, that is giving you only T4, it's not giving you T3. So therefore, that is the argument why some people have said that you could try to give T3 therapy. But at the same time, studies have shown some benefits on mood, on cognition, but it's all very debatable. Some human beings, up to 16%, may have a deiodinase defect. What does a deiodinase defect do? A deiodinase 2 defect actually means that the T4 is not getting converted to T3. This group may do relatively well if you give T3. But are we doing this, gene? We don't have the facilities to do it. Is it cost effective to do it? And that is why some people may not be better, and it's a challenge to identify these people. And these people have worse scores, and some of them do well. So where is the T3 coming from? So reverse T3, which is the inactive form, 30 micrograms per day. T3 is 15% of T3 is coming directly from the thyroid gland, and 85% of T3 comes when the T4 gets converted to T3. And if you look at, so if you look at the T3, if you look, the body makes about 30 micrograms per day. 4.5 micrograms is directly coming from the thyroid gland, and 25.5 microgram is coming from peripheral conversion of the 100. So that's how it's working. So that is the rationale for combining T4 and T3. You get 112 micrograms of T4 and 5 micrograms of T3, which means that the ratio is approximately 14 to 17:1. So in the earlier calculation, I looked at 20:1, but the ratio is 14:1 or up to 17:1 is the ratio. So out of the 112 T4, 100 only is absorbed. That's a bioavailable T4, and that gets converted. So if you give 112 micrograms of levothyroxine, only 100 reaches the blood. Of the 100 reaching the blood, only 25 is converted to T3. That plus the 5 microgram T3 you are giving from outside will give you your good dose. Now, all this is very difficult to do in day-to-day practice. That's how you get 30. So another way to calculate is a simple way. If your patient is taking 100 micrograms of levothyroxine, then you divide 100 by 17. Once you divide 100 by 17, you get 6 or approximately 6.25. And therefore, you can give 5 micrograms of a T3 tablet. And then you take 100 minus this 6 into 3. So 100 minus 18 is 82. So the approximate dose of thyroxine will be 87.5 or 88. So you can actually, for a patient like that, you can give 100 micrograms of T4, you can reduce it to 88 and give 5 micrograms of T3. That is one way to do it. This means 87.5 by 6.25 is about 14:1. It is about a perfect dosing in terms of dosing. Whether we should dose at all, we don't know. Coming back to this lady, you had seen this patient, the 100 was reduced to 88 and 5 micrograms of T3 was added. And therefore, that is the rationale for treatment. So what about if you're saying that there is tissue hypothyroidism, we are giving T4, why not give only T3? Why are you giving T4, T3 combination? What is the need for this combination at all? So to understand that, we must see what is the comparison. Why not give T3 directly? Because T4 is essentially a pro-hormone, a pro-drug. It gets converted to T3. So why not give T3 directly? T3 has to be given several times a day sometimes. So here is a study. There are other studies, but I like this study because this is a CELI study. I really like it because it was, though a very small number, it was done in a very well-designed manner. It was a randomized double-blind. One group, they gave T4, other group, they gave T3 3 times a day. to achieve target TSH. And they assessed all the parameters after 6 weeks after stable TSH. And they found that really there was no difference. But while taking T3, patients had more weight loss, some cholesterol benefits, and therefore other changes were not there. There's no difference in so-called insulin resistance or cardiovascular risk. This is a study. You can see very elegant study. You can see initially when they gave the T3, you can see the T3 is in the round dots. When you give T3, the T3 levels are high and the TSH levels almost similar. And the dose of T3 here was 39.7 split into 3. And what they found is just the changes. Weight came down, fat mass came down, cholesterol came down, LDL came down, but see, all the other things didn't change. The resting energy expenditure, and so many other things, there was not any big change. So therefore, what are the conclusions? What are the take-home messages? One is that optimal treatment with T4 and T3 is difficult because of the lack of a sustained release product. You need to give T3 many times a day. If you ask me personally, there is no clear benefit of giving T3 and T4 in all patients. Some occasional patient may benefit. That is the exception rather than the rule. So it's a very occasional patient. It is safest to follow the American Thyroid Association guideline and just give our levothyroxine. In selected patients who are having persistent symptoms and you have ruled out other causes and you are thinking of T3, you might like to give T3 and especially if the free T3, free T4 ratio is very low, but try to keep the TSH normal, if not at least in the low normal range. I'd say better not to give T3 in clinical practice. So let me come back to my MCQs. So what is the wrong statement about this? I think this is correct. T3 deiodinase 2 is present in the brain, muscle, heart, and thyroid. Deiodinase type 2 converts T4 to T3. It removes iodine from the tyrosyl ring. This is a wrong statement that it is involved in consumptive hypothyroidism. Consumptive hypothyroidism is a rare type of hypothyroidism where there are tumors which produce deiodinases that destroy the T4. And therefore the patient is hypothyroid. And there are, that's very rare disease. And therefore that is the wrong answer here. So that doesn't have deiodinase 2, it has other deiodinases. Second answer is combination therapy with T3 and T4 has a selected role in practice. I think it has a very, very selected role. People with deiodinase gene polymorphism may benefit. True, they may benefit, but you'll have to actually diagnose this and do the genetic test, which is really not possible in today's practice. Maybe with future technologies, we may have that. May be considered according to the European Thyroid Association. Yes, the ETA guidelines 2012 did say that. So the answer is all the above are correct. So I'd like to summarize by saying that T3 plus T4 in 2 words, it is too early. Many T4 patients have low T3. Is that causing some tissue effect? We don't know. We admit that giving thyroxine alone is not perfect because T4, T3 is very high. But adding T3 may or may not be a solution to that. We require more and better solutions in future. Additional issue of the deiodinase gene polymorphism that has to be looked at. So in future, somebody has to do a randomized control trial. We need to have more sustained release in the market. T3, T4 ratio for treatment and target has to be looked at. So these may be some surrogate outcomes people may be looking at. So on that note, I think generally, let's consider only levothyroxine in our practice and T3 should be the exception rather than the rule. But it's good to know that there is a tissue hypothyroidism concept. T4 may not be converted to T3 and therefore that we might like to look at this evolving story in future from the excited view of an academician or researcher to see what's happening to this space. Thank you for listening to me. It's a pleasure talking to you.
So thank you very much for the wonderful and elegant session on enlightening our cellular hypothyroidism, sir. So you are getting great clinical insights, the regulations of both T3 and T4. And also we enjoy the whole thyroid physiobiology. Thank you very much, sir. I call upon both the speakers to the dais for discussion.
Yeah, I think it has been said correctly that the food, physical activity, sleep should fall into the body's habit. You are absolutely correct, Sasank, because habit is the thing which will make it consistent and will abide by it. And I come from a place, you have visited that place that the life is centered on physical activity. So and physical activity from the very beginning of life till the end of life. As you know, we have heard talks on the sarcopenia from Anup, from Sri, and from this time we also heard from two other new speakers. And to avoid sarcopenia, to live a full life, I think exercise is the most. And it was a great talk. Thank you very much.
Thank you, Dr. Das, for your insights, but you need to build muscle to overcome sarcopenia. So you need to do some physical muscle strengthening exercises.
Sir, actually, 28 years female who is known case of hypothyroidism, sir, on thyroxine 100 microgram. Her complaint is main weight gain, sir, around 5 to 6 kg, and he has hair loss. I told her to do the TFT profile, as TSH was found to be 17, and FT4 is 1.17, and FT3 is 2.6. On further evaluation, her anti-TPO antibodies was found to be more than 1,300, sir. So how I have to proceed in this case, and how much dose I have to correct it?
So here is a situation where there is subclinical hypothyroidism. The T3 and T4 are normal,
Yes,
only
sir.
the TSH is high.
Yes.
The patient is complaining of weight gain.
Yes.
So you can start with about 75 micrograms of thyroxine.
Already
That's-
she's on thyroxine 100.
Oh, she's on 100, you'll have to increase it to 150. Now, two things I must tell you in practice. Wait for some time before testing, 2 months. And second is hypothyroidism is not associated with that much weight gain. So if the patient is expecting that if the TSH is going to get better, my weight is going to come down, that may or may not happen. So please, it is important to tell the patient that I'm bringing down your hypothyroidism situation. I'm making it better. I'm normalizing the TSH. This may or may not translate into benefits such as you mentioned, there is hair loss and weight gain.
Yes, sir.
Both these things may not get better. Weight gain, there may be a possibility. Of course, she should follow diet and exercise. And the hair loss, there may be other autoimmune, alopecias associated. And anyway, hair loss is very difficult to treat, and thyroxine may not be the only factor. So you should set the expectations right, increase the dose to about 150 and see whether it comes down after 2 months.
Anti-TPO antibodies is more than 1,300.
Anti-TPO suggests that there is, I would like to use the word long term. So the studies showed that people who are hypothyroid and who are anti-TPO positive are likely to need the treatment for a longer term. That's the only implication. And please request her not to test the anti-TPO again. And also that if somebody else has suggested, many times, some practitioners suggest steroids. It doesn't work because this is an organ-specific immunity. The immunity is happening within the thyroid capsule. So giving steroids from outside will not work. So that you'll have to tell her in advance there is no treatment. So your views.
So, I think I completely echo what he said. 3 simple points. One is hair fall. This is hair fall season. Normal hair lifespan is 3 months. What happens in hypothyroidism when you give thyroxine from outside is that hair lifespan becomes 2 months. So more hair is called telovision F1. So more hair is being seen by the patient, perception. That's the commonest medical emergency a thyroidologist like Unni gets or I get. Okay, in winter season. That's the one thing. So reassure. And as Unni said, rule out autoimmune alopecia. That's the first thing. Second thing is break the myth. In 1940s, in United Kingdom, they used to use thyroxine extracts for losing weight. It's a banned drug for weight loss. It has no role to with weight loss. Connection is very poor. People have a myth that I take thyroxine, I will lose weight. In fact, many of these spurious elements which put concoctions for losing weight have some thyroxine powder in it. It can cause tachycardia, it can cause arrhythmias, it can cause atrial fibrillation. So that's the second thing which you need to recognize and be very, very mindful. Third is the antibody. There is so much of Googleization and WhatsApp University marketing of this antibody that patients come to me and say that I am a Hashimoto
as if Hashimoto is some big scientist and he's suddenly born from planet Earth. You need to reassure the patient that this is just the indicator of autoantibody. The level doesn't really determine it. As Unni said, don't repeat it again and again. Break the myth that these antibodies just tell us the etiology and nothing more, nothing less. And there's no therapy for this. And please don't keep repeating it all the time. So I think it's all about communication and handling and educating the person living with thyroid disease. They're often distressed, and therefore it's important to recognize that. But only wonderful talk.
Self-help and positive thinking are wonderful. You mentioned about social determinants of health as well. It was ulta, like whatever you talked the other session. And now I'm glad we agree with you.
Thank you. Thank you, sir. I thank both the speakers for the wonderful sessions.
Okay. See, in Finland, that is why we don't invite general physicians, okay? In Finland, there's an institute where they house all the newly diagnosed diabetics and give them teaching for 2 days. Here, people like you invite general practitioners and general physicians and expose them to all the wonderful, expensive drug. That is why our diabetics are that is why I fought with you. Okay, so you let outreach. At least we can have a session for you all talk 7 habits, but you don't go to outreach. So let us go to the people who pay for us, and at least pay for me, not for you. Okay, Uni, is Eltroxin the best one? Because now you know that MNCs they outsource. There are a number of when I was like you, only Eltroxin. I'll tell them that that pink color GSK. Now so many things, and there were reports in the media that they outsource to Indian scenario and use their multi. What is your favorite? Of course, in insulin he likes all this.
So due to lack of time, I hand over the session to the organizer. We don't have time for anything.
So as long as it is a government approved brand, all
What do
levothyroxine,
you prefer? What do you prefer?
I don't
We
have a
prefer-
choice actually. Generic or levothyroxine in any form approved by the government is equally good. So I don't have a preference here because it's a very simple drug to,
There were
treat.
reports.
So
I support Sanofi, though they don't have patent, metformin. Their setup is best. It's not that I'm against Sanofi, okay? And don't think that you only have sense. I don't have sense. I don't have this.
We
but
talk
I have
science.
common sense, okay?
Thank you.
So
Thank
one
you,
thing, one thing, just a point on this thyroxine bioequivalence. I think you make some valid points on science. Science points, we will dialogue. So the political points. So now like hear out the bioequivalence question. I think Uni, you make a point. Bioequivalence in thyroxine matters. Do not do change of brands, particularly in pregnancy. So because there is a filler in every thyroxine, and therefore the global recommendation is, and all the global societies have studied, that try to have a bioequivalent brand. We assume that the DCGI available brands are bioequivalent. The only request to everybody here, and including Karunanidhi ji, is that do not switch brands during pregnancy, period.
Thank you.
I think unnecessarily don't change the brands there because that lead to some destabilization. So especially in pregnancy, and otherwise, unless there is a need, there's no need to change the brand. Completely agree.
Thank you, sir. So I thank both the speakers and the chairperson for making this session wonderfully. So may I move on to the next session? So may I invite Dr. Krishna Sheshadri sir and Arvind Sosle to take forward next sessions.
Thank you. Thank you very much. To me, this is a very, very special, a special moment. All of you know that debate is very unique. That we showcase all that is best, all that is wonderful, and all that is transformational, all that you can actually start doing in your day-to-day practices. As we keep expanding the envelope of debate, one of the things that you will see today, Shashank, I don't know if Shashank's here, Shashank was talking about the effective habits, highly effective habits of people. And he did talk about the toxic ego. He talked about spirituality. He talked about science. If you look at the biggest scientists in the world, whether it's Niels Bohr or whether it is Einstein, they would never deny the existence of spirituality and science. And the other way around, right? It takes a very big ego and little knowledge to deny that there are open fields in the mind that require to be explored, that require to be inquired, that require to be probed, that require to be asked, and find out how it makes us better persons, right? Whether you're going to have, whether you believe in the Atma, whether you believe in ultimately Mukti, it's a good idea to start sowing those seeds now. But what we also now know is that your spiritual part plays a very, very important role in the physical and other well-being. And we know that this influences outcomes, including our metabolic outcomes. So given this long introduction to what I hope is a regular, recurring topic in debate, I have again someone who we'll have difficulty in matching next year. A person who's somebody who I have admired from the time I've seen her walk around the cadavers in the anatomy department, make a special effort to help students who were not, who had challenges with English, making sure that each of us understood what is happening, and continued to support people over a period of time. And it's just our fortune that her other side, besides being a great teacher, a great scientist, a great anatomist, is the fact that she's probably one of the country's leading spiritual speakers. Recently, she spoke at the Kashi Tamil Sangam. Our shared passion is the Lalita Sahasranama, but she beat me to the book. But let me introduce Dr. Sudha Seshayan. Please give a big hand. She's the most wonderful human being I've known. Ma'am, thank you. Arvind, Shashank, can you come up on stage? So I will no longer stay between you and Dr. Sudha Seshayan, and she will take questions also, so please.
Shri Gurubhyo Namaha. Vanakkam. Thank you very much, Krishna. I don't think I need to spend any time on introducing this particular area. Krishna has done it well. What Krishna asked me to speak about this afternoon is intersection of science and spirituality, and how could it help the patient care. Before the intersection, there are a few questions which I would want to raise here. How many of us think science and spirituality are related? Krishna did quote or at least cite Niels Bohr and Einstein and so on. Nevertheless, how many of us sincerely believe science and spirituality are related to one another? The corollary also surfaces. Where are the areas where science and spirituality differ from one another? I would not try to give certain advices here. I'm not here to give you advices. But before I try and say something about science and spirituality, put together or divergent from one another, let me try and recap some observations which all of us would have made at some point in our lives. Observation 1, most thinking minds desire to be called scientific. Stop a mathematician. Stop a geography expert. Stop a Vedic Pandit. Stop a vegetable vendor. Ask him or her this specific question. Do you think you are scientific? Let the question be truthful, let the answer be truthful. Everyone wants to be called scientific in some way or the other. None of us would want to say, no, I'm not a scientist. Our career could be something different. Our style of work could be something different, but then all of us would want to say, of course, I don't do direct science, but I'm very, very scientific in my temper. This is human thinking. This is the human psyche. Observation 2. Almost every thinking mind also desires to be spiritual. The reason why everyone wants to be called scientific and everyone wants to be labeled spiritual, we have a construct that science is something of intelligence. We have a construct that scientists are the most intelligent beings. We also have a construct that spirituality is abstract. Anything that is abstract has no known dimensions. No known dimensions indirectly will mean immeasurability, and immeasurability will also mean somewhere in the higher planes. So each one of us would want to be called spiritual and scientific. Observation 3, science and related scientific facts are born out of questioning. Questions which have also led to spiritual enhancement. In other words, cite Aristotle, cite Rudyard Kipling, cite Hermogenes, Any of those people who talked about the questions and the questioning, let's understand science and spirituality are born out of questioning. Observation 5, science disregards external appearances and tends to look into internal truths. It is not the external appearance of an apple falling, but it is the internal truth of the gravitational effect. Observation 6, by now you could have guessed, spirituality disregards external appearances and focuses on internal truths. And most importantly, observation 7, science and spirituality are not contra to one another. Unfortunately, we tend to think science and spirituality are opposite dimensions. They are not. Both tend to seek, both are based on knowledge, both experimental and experiential knowledge. Both attempt to empower and both factorize inner joy. If it was the eureka moment for someone, it was a moment of inner joy. If it was the Sukha Brahmam moment for someone, it was again a moment of inner joy. Putting these together, science and spirituality, which are not contra to one another, can we do something synchronizing them, adapting them to the cause of patient care? As rightly pointed out by Krishna earlier, every health compromise has a psychic element. The mother comes to you with some skin manifestations. Many of us tend to treat her dermatological issue, least realizing her son had gone away to another country 6 years ago, no contacts, all the stress, and all that is reflecting on her skin. No information to the treating physician about the son who has gone away. The mother refuses to talk because she does not want to remember all that. What happens to patient care there? I would like to recall a very famous story. Some of you might remember as to where I'm leading to. There were 4 boys. They were laid in 4 different cradles. It so happened that 2 of the boys were screaming away to glory. Screaming away, crying, weeping. Small children, infants, they were. They were the children of an emperor. And all the Vaidyas were brought in from all over. The palace Vaidyas. The doctors who could heal. Each of the Vaidya tried some kind of a measure to make the child calm. 2 were sleeping, 2 children were screaming. All kinds of efforts were made. Nothing worked. 2 of the children continued to cry. The mothers were worried, the father was worried, everyone around was worried. And then someone called the preceptor. The preceptor duly arrived, stood there for a few minutes, looked at all the 4 children, looked at the cradles, separate cradles, golden cradles, because the emperor could afford to make golden cradles. He stood there for a few minutes, took in his hands one of the screaming boys, transported him from one cradle to the other cradle where another child was calmly sleeping. The scream disappeared. He did the same thing to the other child who was again screaming. Same effect. Some of you might have recalled as to which story I am trying to relate here. The 4 boys were Rama, Bharata, Lakshmana, and Shatrugna. It is customarily said Lakshmana and Shatrugna did not want separate cradles for themselves. Vasishta took Lakshmana and put him in the cradle where Rama was sleeping. Lakshmana became calm. Shatrugna was similarly lifted and put in the cradle in which Bharata was sleeping. And again, the same effect. Now, it is not anything else but the psychic element which was creating a problem, and all the Vaidyas were trying to treat external factors when Vasishta was able to understand there is something else inside. This incident might have happened, might not have happened. I'm not worried if it did not happen. But it gives me a lesson to understand that the psyche plays a very important role in all physical manifestations. And whatever we talk about, allergies, acid peptic disease, and whatnot, everything has a psychic element. Every patient has a mind. And the corollary, every healthcare professional also has a mind. And whatever we do, whatever state of mind that the healthcare professional is in, will definitely affect the care imparted. Faith in spiritual practices, belief in divinity, trust in oneself, call it by whatever name you want. All these factors increase the emotional strength of an individual. And all of us do know that emotional strength plays an important part in treatment outcomes. Again, an age-old story. I'm not here to say that someone carried the mountain, but I'm here to say the mountain or the herbs on the mountain were never used. The herbs were not used at all. The story only goes to that extent that Anjaneya brought the mountain. He did not even place it down. For those of you who might be a little curious, please think, where is that mountain? It should have been placed in Sri Lanka somewhere. No, it was not. It was taken back. The story says it was taken back. That's another part of it. But then the mountain was not used. The herbs were never used. But how is it that everyone came back to life? It is that inner strength that came out of the confidence. Here is someone who will take the efforts to help me. Here is someone who will support me. It is that confidence in a support system and treatment outcomes do matter are based on the support system. It is the support system which reduces the disability factor. Now, several times people tell me there seems to be an increase in certain diseases like Alzheimer. But then I have a counter argument. Yes, there could be an absolute increase, but also think of the existence of a support system. Let me put it this way, point blank, an old man living in an urbanized situation, no one to support. The son, the daughter-in-law, the grandchildren go off. He is all alone. Evening they come back, they complain, oh, this old man keeps forgetting. Disability factor. The same old man, amidst a support system where there are some children playing around, that child who may not even be a biological descendant of this old man would probably come and say, Tata, you wanted to go to the temple. Have you forgotten? Let's go. Now the disability factor has disappeared. No one now complains Tata had forgotten going to the temple. But then in the first instance, everyone complains Tata has forgotten something. It is the existence of the support system. And spiritual practices give that confidence that there is a support system. It could be divinity, it could be Godhead, it could be someone, it could be something, it could be yoga, it could be anything, but then the confidence in a support system. Small built-in practices. Many times we call them spiritual practices, but I personally tend to differ. These could be practices which could lead to spiritual enhancement later on. But these small built-in practices ensured need fulfillment. What you see there is a domesticated cow which is trying to lick at the wall. Why? Cattle which have been domesticated, they tend to lick the wall. It is a need gratification. They require some calcium. And when they find some kind of, painting that had been done, earlier days it was slate climb, something like a salt lick in the forest, these cattle go and lick. So it is a kind of a need fulfillment. And some of our practices, built-in practices, were based on the fulfillment of our needs. Today we talk about Surya Namaskar. We talk about the procedure of Surya Namaskar, but then this is a country where people take long walks or short walks in a hot or a humid temperature. And this is also the land where we currently tend to think of prescribing all kinds of defortified medications. Small little practices, getting exposed to sunlight, walking for short distances. Think of our ritualistic weddings wherein people squatted on the floor and ate. 30 years ago, when I was in college or a little earlier, I remember dining tables used to be luxuries. Now dining table is part of our regular routine furniture. We've forgotten how to sit on the floor. And we talk in terms of all kinds of orthopedic problems which have increased. The elastic recoil that one obtained from the floor, the elastic recoil is lost. I'm very fond of quoting a particular incidents which happened a few years ago in an institution in which I worked. Let me repeat it. The animal house had to be demolished. The old existent animal house had to be demolished for some kind of construction purposes, and a new animal house was built. Krishna would remember the kind of moat arrangements that any of these cadaver positioned laboratories used to have. When the new animal house was built, since I was in charge of the administration, I had a fight with the construction engineer and the architect. They were adamant that they would have only tiled flooring, vitrified tiles. Call me an old generation representative, but then I thought the animal house would be much better with a cement flooring. The architects would not agree, the engineers would not agree, and I could do nothing about it. Beautifully tiled, vitrified tiled flooring for the sheep house. 15 days, and their logic was impeccable. They said, ma'am, you have no idea. The animals would soil this place and it's easy for cleaning. Tiled floor is easy for cleaning. I said, fine. Okay, let's see. 15 days, all the sheep developed bow legs. All of them. And we had to break the tiled floor, redo the entire place. But what damage was done was already done. I'm not trying to say that we need to modify all our lifestyle changes, but can we not think of incorporating a few practices when we prescribe certain things to our patients? Spiritual wellness enhances the dimensions of our age-old definition of physical, mental, and social well-being. What is spiritual well-being? This is what I found. Spiritual well-being enhances immune system, promotes healing, diminishes all those hormones which lead to all kinds of toxicity, not necessarily toxic ego, but then toxicity across, delays disease progression, gives hope and sense of purpose. That is what is the most important. It gives hope. And of course, correlates with physical health. If wholesome wellness is intended to, the spiritual component cannot be overlooked or sidelined or even ignored. Today, what are the components which go into good health? We talk about the food, we talk about exercises and so many things. I'm not here specifically mentioning about the importance of some of these exercises, be it in the name of exercises or physiotherapy or yoga or whatever. Now, I'm not trying to say yogasana should become a package deal for the practitioner. No, but then there can be practices which can be identified, rejuvenated, practices which are inherent to the particular individual, practices which they have been doing for years together, or practices which would fit in a particular patient in a particular situation. When asked about tips for well-being, this is what people say. Be an optimist and accept oneself. And what does spirituality do? It makes one accept life. It makes one an optimist. Yes, there is something beyond my control. There is some power which would definitely help me, and that power will make me accept myself. That is what is the most important. Accept life and accept oneself, and that comes from both science and spirituality. Now, friends, there is something which I would want to reiterate here. When we started, I asked you a question, rather kind of floated a question. How many of us think science and spirituality are related? Very many times, we tend to think science and spirituality are opposite faces. We tend to think science is one side, spirituality is the other. But please remember, science and spirituality are not opposite facets. They are the two surfaces of a single coin. There could be a kind of a remark here. If they are the two different sides of a single coin, they are opposite one another. No, they are not. Can you ever think of a coin existing only with one side? Let it be the coin from the US or the UK or Malaysia or Indonesia or even our own Indian currency coin. Can any coin exist with only one side? It naturally has to have another side. It may not be as embossed as the other side is, or it may not be, as glittery as the other side is, but still there will be another side. No coin will exist with only one side. And when I say sides of the same coin, please remember, they do not oppose one another. They face the opposite sides, that is all. They face the opposite sides so that a complete view is obtained. I look at this side, I do not know what's happening on the other side. And it's this facet which would probably get me the visibility of the other side. The two sides of a single coin do not oppose one another. They take in the opposite views, they take in all the opposite remark and then try and work out a consolidated whole sum. If Janus can have two heads, yes, I do not know what we could call it. Science and spirituality put together. Krishna, probably by the next debate, you could think of a word, coin a new word, which is an assemblage of science and spirituality. Our purpose is one, our objective is one, and it's one patient, one health, one universe. And to fulfill the requisites of the objective, science and spirituality can go together. Friends, as I told you earlier, I'm not here to give you advices on how spirituality can be included in your day-to-day practice. It is for each one of us to find out ways. It is for each one of us to rethink, but I'm here only to reiterate, adding a little of these spiritual practices in our prescription could go a long way in patient care and our healthcare responsibility. Thank you very much.
So thank you very much, I was sort of reminded of Ekam Sat Vipra Bahuta Vadanti. Maybe they are the same. Who knows? We'll find out. So any quick questions? Dr. Das, you want to? He's satisfied. So any questions from the audience? Yes, sir. Krishna Prasad.
Madam, because you are a great administrator, why can't you keep this as a part of the curriculum, at least for the postgraduate students, because it's a writing of the prescription, cut, copy, paste from the digitalization of the prescription, not only something we have to include in the curriculum so that it has to be translated into the practice. I am a physician practicing for 25 years. I have been doing. So as a lady physician, what you have told that the dermatological manifestation, every blood sugar, every blood pressure, numerical value has something beyond we have to see. So we have to read in between the lines, I feel. Thank you very much for giving a lot of insight on this.
Thank you, ma'am. I do agree. May I finish, sir, or you would? Yeah. Definitely not, sir. Yeah, thank you. Ma'am, you're absolutely right. However, at least as far as medical education and related areas are concerned, there are regulatory bodies, so there cannot be anything that one individual can do or one regional agency can do to put into the curriculum. However, there is some good news for all of us. Experiential learning has been made mandatory in all the medical and paramedical curricula. And as part of experiential learning, all this is being brought in. So maybe in the next few years, we would have some of these areas addressed. And yes, this cannot be complete. Like, you cannot teach something. You would have to make way. And I'm sure in the next couple of years, all these would get into the curriculum also.
Madam, Krishna wrote the forward to the curriculum of NMC and he has hinted at it. And I'll say 2 points, madam. You have beautifully built the story around spirituality, which is different from religion. And you have given beautiful examples how spirituality have to be embedded in daily practice. Madam, do you believe this spirituality in a physician or a doctor can bring in the element of intuition, the sixth sense?
Yes, sir. Number one, I basically believe spirituality and religion are slightly different. Spirituality is based on knowledge. Religion is based on the whatever kind of, something like a godhead, you have a cult or a cult head or an individual, and religion is based on that individual or the cult head. Of course, all religions talk about good things is a different issue. Like a law comes in, as long as there are only two people, the law remains a law. More number of hands, there are any number of amendments. Same thing happens with religion. Now, coming to the second aspect, yes, intuition and sometimes even a kind of, gut feeling that could help the practitioner. I think Krishna would remember, we have had several of them before, like, people who, all our stalwarts would kind of talk about something uncommon suddenly just because my gut feeling, please do this investigation, you will find it. However, in times of consumerism, gut feeling alone may not help. And I think we need to take care of that aspect of consumerism and maybe make people aware that spirituality does help.
One and then last question to you, sir. Always.
Hello, madam. I'm so happy. I'm glad I came here. I heard what you said. From the example that you told in your speech, a lady's example where her children went to foreign country and she's alone. And see, and you also said one thing. She is not okay with speaking about it because she doesn't remember it. And you also said that's reflecting in her skin disease. So given what is, if she addresses it, if she remembers and she speaks about it, the skin rash would be gone. Am I right, madam?
See, I was just trying to give you a situation, a life situation where bottled up emotions, the person may not, unless the practitioner is trying to pull it out, it may not come out. And I specifically said a woman because generally, the women tend to keep things to themselves and not want to reveal it to a third person whom they would consider. The practitioner would still be thought of as a third person. We've done away with the system of family physicians and all that. So kind of, it may not come out. So I was only trying to give you a hypothetical situation.
No, ma'am. Actually, I didn't see it as a hypothetical situation, like from what you said. But coming from a doctor's family, all my fathers, all four of them are doctors, each in an own department. My father is from government, and I myself doctor. And I had some issues which our seniors and even more things couldn't handle, which is like hemorrhoids, and I had continuous acidity for a pretty long time, from my medical college time until I was in UK studying for MRCP. Like around 10 years I had that issue. And given all the diet formulas, other things, it wasn't helping me in the long run. I had to keep myself always in the hypervigilant state to not get an acidity. And so I started looking for alternative ways, and I came up with a book called from Louise Hay, which she said, like said, every physical ailment has a psychic element in it. And I looked at the list she gave. I mean, like madam said, reading between the lines. So then when I addressed it and I started expressing out instead of bottling it up, the acidity went away and I am free of it from 2014 to 2023. I don't take any medicines now, nor do I have any endoscope. The piles is also gone. I don't know how it just resolved on its own.
It is venting one's feelings, like, you need someone. I'll just give you one small example. Krishna, pardon me for 2 minutes extra time. See, I mean, something unrelated, not necessarily leading to a kind of a physical illness. I have worked with educators, people who head a school administration or a college administration. Every time I used to go to the institution, there will be people, there will be, those administrators, women administrators, would come up with a long list of complaints. And they'll say, ma'am, this is problem, this is problem, this is problem, this is problem. But over the course of years, I understood one thing. I don't have to give them solutions at all. I just have to give them a patient hearing. The moment they reel out all their problems and complaints, they also know their solution. In other words, it is the bottled up thing that needs to come out. The solution is not in a medication or what we think as a solution, give an answer to it. The solution lies in that stress being dissipated. That is essentially what spirituality does, dissipate the stress factor.
Yes. We become what we eat. This is how we unite spirituality and science in diabetes. We wish that all our vice chancellors are really vice chancellors, WISE. That is why they are still not able to find out a good vice chancellor for our university. You talk about spirituality. Do you practice spirituality in your work? Have you ever come across any, speed breakers? Have you ever regretted for not doing what you think is spirituality, but you may not be able to implement it for administration? Anatomy and administration and spirituality may get along, but administration is, as you know, ours is a corrupted country, poor governance. Your experience about spirituality, of course, you could quote how we met. I came to you 1 mark for 13 students. your spirituality, you should have called the students and spoken to their parents. You simply ran away from the, so how can I believe you that you are a spiritual person? Maybe you talk. Walk the talk. That will be real spirituality.
Thank you, sir.
We practice.
Thank you, sir. Spirituality is. Okay, sir. Thank you. Thank you very much. Thank you.
Yeah, request everyone to settle down because we're going to have a great talk by none other than Dr. Anup Mishra. Voice is not coming? Okay, it's coming now. Okay, thank you. So we'll have the last talk of debate 2023 coming from Dr. Anup Mishra. Well, he requires no introduction. He's been a professor, chairman of the 40s CDOC Center for Diabetes, Obesity, Metabolic Disease and Endocrinology. He's the chairman of the National Diabetes, Obesity and Cholesterol Foundation. He's the director of Diabetes Foundation India. He's also the life trustee of Research Trust of Diabetes India. He's been awarded the Padma Shri by the President of India in 2007. So, I mean, there's a big list, but he's been a great mentor to many of us in Diabetes India also. Dr. Anup Mishra would be speaking about pre-meal loading, a new concept in nutritional management of glycemia. Every time I eat before the lunch starts and puts my hand and tries to eat a few things, I would get a hit from my mother and grandmother. Now my wife says that I cannot snack before the meal, but I would love to listen to this lecture, pre-meal loading, a new concept in nutritional management. Dr. Anup, the stage is all yours. So we would be sitting down to listen to your lecture.
Thank you. It's always difficult to speak in the last, especially when you're all hungry. Some of you are going to the airport, and we had brilliant speakers before us. My thanks to Dr. Krishna Sheshadri, Dr. Prasanna Kumar, Dr. Arvind, everybody, and it's wonderful to see Krishna in traditional dress. So that sets the mood. So, I'll not take much of a time. I'll take just 15 minutes for this new concept. We all talk of research. In India, research is very much less, and something which is desirable, that we should all do research. So especially in nutrition, because nutrition is something which is unique to us. And that's where I'm going to speak on. But before that, just to give you a background, especially about the pre-diabetes. Why pre-diabetes? Because we can reverse pre-diabetes very well to normal glucose regulation. But it is something which is going up and up. And if you see our review of 1.7 million people, we published that review, and look at, forget about this we know. But look at this, pre-diabetes, and especially in the semi-urban and rural areas, it is going to surpass. So this is something which is our target. This is something we should aim at for reversing to normal glucose regulation.
But it is difficult. This is difficult as far as Indians are concerned. Look at this. From normoglycemia to diabetes, our blood glucose rises faster and 1 decade earlier than Western people. And also, if we want to reverse back using a diet and lifestyle, then see the progression is 12 to 18% per year, and 30% can be reversed back to normal glucose regulation. As far as the Indians are concerned, and look at the Western population, much less progression from pre-diabetes to diabetes, and much more regression to normal glucose regulation using the same diet and lifestyle. So we need to aggressively implement the nutrition and exercise at the pre-diabetes level, more aggressive than other population, and maybe at an earlier age. Another thing that you all know, but just to recap, that it is not the fasting hyperglycemia which is a predominant in any of us if we have developed pre-diabetes or diabetes. Look at this. Most of us are in postprandial state for 12 hours of our time. So postprandial hyperglycemia is important. And the fasting state is only 3 hours. So postprandial hyperglycemia should be our aim. So the background is a number of dietary approaches have been tried for glycemia control, and that's beyond the purview of this particular lecture. Regression to normal glucose level from any level of hyperglycemia is important and should be our priority for Indians who have fast progression from pre-diabetes to diabetes, and simple, very simple, yet innovative diet which is culturally appropriate should be researched. Now look at this number of diet. We talk about keto diet, we talk about intermittent fasting, we talk about low carbohydrate diet, a high MUFA diet. Any of those can be used for prevention from healthy to pre-diabetes or diabetes, or regression from pre-diabetes to diabetes to pre-diabetes and normal glucose regulation. But these are extreme diets. These cannot be followed for a long period of time. That we know, and any of you who have done keto diets will know that more than 1 month time, it is virtually impossible to follow. So majorly altered diet, very low calorie diet, extremely low carbohydrate diet, very high fat diet, or high protein diet may be effective, but long-term adherence or compliance of diet is a major issue. And preloading each meal with protein or fat or tailoring the sequence of macronutrient ingestion have been proposed as a strategy for prevention and management of postprandial hyperglycemia. A limited number of studies are available here. Now look at one such study. I'll give you an example of a couple of studies which are available from Western countries. Now this is a study which was published in Diabetes Care. 10 people with type 2 diabetes preloading with 330 gram of soybean and 75 gram yogurt. Now, if you look at this, if you look at the glucose levels, or you look at the free fatty acid level, or you look at the insulin level, all decrease in those people who preloaded. And they said, these authors said, consuming a high protein pre-breakfast snack results in 40% reduction. They say it is as good as a DPP-4 inhibitor. 40% reduction of postprandial glucose increment. So this is one of the previous studies, 2010, 13 years have gone by. This is the Japanese study. Japanese take a lot of rice, and what they have done is two sequences. One, rice first and vegetables later, and second is vegetables first and rice later. Once they took vegetables first, look at the plasma glucose level, plasma insulin level, and on continuous glucose monitor, you see in patient with type 2 diabetes or normal glucose regulation, how the peaks of the postprandial blood glucose are blunted majorly. So this is again in Japanese people, again, so different ethnic group, it works. And this is the only study as far as almonds are concerned, randomized control trial of 20 people with type 2 diabetes preloading with 12 almonds, 14.2 grams of almonds, and test meal is 75 gram glucose. And look at this, the almond preloading, what happens at a 1 hour glucose and a 2 hour glucose. Mean 1 hour glucose reduced by 19.4%, area under the glucose reduced by 15%, 8-patient reduction by 45 to 110 milligram per day. Look at the amount of reduction, 4-patient reduction by 22 to 32 milligrams. So taking cue from this particular study and rest of the study, we designed this research. Nuts, because it's a part of our culture. Almonds is known to everybody, and people are generally convinced that almonds are good for health. And 3 phases study, oral glucose tolerance study, continuous glucose monitoring study, and a 3-month study. So 3 studies. And we had earlier done a study in patients with diabetes, almonds as a snack, and we had shown already as a pilot that it works as far as diabetes is concerned. Adult patient with the pre-diabetes, almond load, not 12 grams, but 20 grams, 17 to 18 almonds in like 30 minutes before the meal. This is the OGTT and CGMS based study. These are period 1 OGTT study and then crossover. These people were tested for controls, were crossover to almonds, and period 1, 2, or day 9 in between, there's a washout period. This typical crossover design, and similarly for CGMS based study. This is our publication, European Journal of Clinical Nutrition, just a couple of days back on this particular study, the OGTT based study. Now, if you look at this, we did a number of parameters. Beside blood glucose, insulin, C-reactive protein, etc., we also did DPP4 level, GLP-1 levels in the blood, everything. But those which are significant are being presented here. Look at the blood glucose level. This is the almond load, 18 almonds. And then subsequently, this is minus 30 minutes before. 0 hours, the 75 gram glucose were given. And look at the almonds. C-peptide, look at the serum insulin level and serum DPP4 level. DPP4 are actually injurious to them. But there's no difference as far as GLP-1 levels are concerned. So this clearly showed that in our study, in larger number of patients than ever before, in Indian population, that it works very well. And magnitude, how much is the magnitude? Look at this 5 to 35 milligram% postprandial glucose level in 28% of the patient, 36 to 70 milligram blood glucose level in 60% of them, and 71 to 105 in 11%. Overall, PP hyperglycemia area under the curve reduced by 18.5% in OGTT-based study and 10.7% in CGMS. Very clear, very convincing research using 2 studies. Now, these are the studies which are just a couple of days in duration of OGTT and CGMS is 3 days duration. Look at the CGMS study. This is 3 days using a Medtronic CGMS device. I'm not going to detail, everybody knows that. We looked at the CGMS parameter, and this is our CGMS of one such patient, a 41-year-old male with pre-diabetes, 3 days of continuous glucose monitor. Here is a controlled diet. Here is the almond preload diet. Look at the excursions here, and look at the excursions totally gone in this particular patient. This is the best day, and there are other days also where the excursions are gone. So clearly it is working on oral glucose tolerance, that was a 2 to 3 hours study, and 3 days continuous glucose monitoring study. Look at the controls, 30 controls, average CGMS values, and almond average CGMS values. So this is something which is clearly demonstrated that it is working in all patients. What about the glycemic variability and glycemic control? And number of parameters were used. These were statistically significant. These were not. In standard deviation of mean of daily reference, glycemic control, but particularly postprandial hyperglycemia and overall hyperglycemia was significantly different. So till now, we have reached 3 days of CGMS. We need to do more. We have to drive the nail 3 times to clearly advise. And then there is going to be no further study. Let me tell you that. Because this is so convincing. This is how a research should be done, actually, that you drive home a point and then subsequently there is nothing else to prove. Maybe a 1-year study to prove, that's about it. So a 3-month study. This is the 60 number of patients run in with diet and exercise, randomization to pre-meal almond load, and then standard diet. And then this has been published in another paper, Clinical Nutrition, just a couple of days back. Now, this is the composition of diet. Those who are nutritionists, the diets are almost the same with some slight difference as far as protein levels are concerned. Look at the percentage decrease in outcome parameters in 90 days. This concerns more of clinicians. Look at this. The weight, BMI, waist circumference, hip circumference, sum of skin fold, they all decrease. Hand grip strength, suggestive of the increase in the muscular strength, increased. And specifically, if you see the postprandial glucose, postprandial insulin, HOMA-IR, all substantially decreased, in addition to lipid levels and hemoglobin A1C. And if you look at the reversal too, so we talk about reversal of diabetes and we are using a low calorie diet or low carbohydrate diet and so on. And here is a reversal of diabetes using non-restrictive diet. We had not restricted the calorie. We just matched the calorie and gave the almonds. Here, if we take fasting blood glucose and 2 hours post oral glucose load, 23% reverse back in almond arm. If we take only fasting blood glucose, then 33%. If we take 2 hours blood glucose, 76%. Look at the impact on the postprandial blood. And if we take the hemoglobin A1C, 30%. And if we look at the individual parameters, postprandial insulin, pro-insulin levels, HOMA-IR, the body weight, waist circumference, body mass index, and subcutaneous fat, skin fold, 4 skin fold, and these are all decreased. So it's not that incorporation of almond in diet will increase weight, or in fact, it will decrease weight. Besides changing, impacting the postprandial blood glucose and reversing people to normal glycemia. And very interestingly, hand grip using a JAMA dynamometer increased, meaning thereby this, if there's somebody sarcopenic, then it improved. Now, there are multiple mechanisms which have been shown to be operative here. I don't know what is operative as far as our patients are concerned, possibly delayed gastric emptying and decreased appetite using almonds. We have the appetite scores and so on. I don't want to go into detail. People say that it decreases hepatic insulin clearance and insulin secretion. We did not see increase in the insulin. In fact, we did see decrease in the insulin secretion. And GLP-1 level, other studies have shared, we have shown no increase in the GLP-1. So some other, possibly these two are more operative as far as our patients are concerned. So I summarize my presentation. Emerging research shows that a pre-meal load of non-carbohydrate food. Now, if you don't want to take almond, you can take protein. There are examples of protein. You can take vegetables, or you can soya. Many things are possible 30 minutes before. In a serial study, clearly establishing for the first time as far as Indian population is concerned, that preloading of any of these nutrients is important and decreases postprandial hyperglycemia and may reverse diabetes, and also decreases weight, subcutaneous fat, improves hand grip strength. Reversal to normal glucose regulation from pre-diabetes is possible with this strategy. And such strategy can be applied where else? Beside type 2 diabetes, where else? Where we cannot use pharmacological agents. For example, type 1 diabetes. It is very well suitable for type 1 diabetes because insulin is the only answer there. And gestational diabetes, again, insulin is the only answer. There we can use it, although I must say we have not shown that in this segment, but applying our results into this segment, it is very well possible. So thank you, Arvind. Thank you, Krishna, for giving me this opportunity.
Thank you so very much, Dr. Anup. Questions, I think I'm sure there'll be a lot of questions. Krishna, you were supposed to chair the session, but it's okay. You can ask questions from there. You can go to the podium and then Dr. Anup will answer the questions from here.
So I have a question. So my first thing is it only a nut? First thing. So if I have some mixture or muruku half an hour before, does it count?
Muruk, I mean, some snack, oily snack, chips.
See, Krishna, I'll tell you where it has been, many other things have been tried. I've shown the vegetables before rice. I've shown the soya protein, that snack before. Pure protein of 25 gram, pure protein of 52 grams have been tried earlier. So I think many things work. It is not nuts, not that big, because we were familiar and we have done a number of studies previously with nuts. And that's why we use this. We had the funding also from Almond Boards of California. So we were in good position to try this.
Right.
But I can tell you, except if you are using something which is made of lots of trans fatty acid and hidden sugar, then I don't know. But if you're using a healthier thing like this, is going
The
to be-
second question is, before we get one more, is the timing, right? For example, during the day, is it related to a pre-lunch? Or could it also be pre-breakfast and pre?
He has done it 3
Yeah,
times,
I
pre-breakfast,
understood,
lunch and dinner.
But
He did
just
it all the 3 times.
once
in fact.
again, the reason I'm coming to it is, Banshi is now talking about that if you delay breakfast and actually have an early lunch, which a lot of South Indians do, then he says that timing makes a difference. So the question is it also the timing of the meal that comes in?
Maybe, but we have not looked into that research question. But one thing is clear that we have used, as Arvind has said, 3 times a day. And in our paper, we compared this to acarbose. And we found that almost similar, although I must say, stop, and I didn't longer duration trial, and this is just 3-month trial, but we compared the proportion of postprandial decrease and it's similar.
Absolutely. Dr. Krishna Prasanthi, Dr. Das, you also? Yeah.
Sir, in the START study, pan-India, they were seeing that almost 60 to 65% is the carb content of that. So in South Indians, and if you compare with the North Indians, the type of the breakfast, everything, it matters a lot. And now people are following of the intermittent fasting of 12 hours from night 7 a.m. to morning 7 a.m. like that. So I think because as a physician in Tirupati, last year we have conducted with the Vedic University and the Central University along with the Ayurvedic doctors, what exactly is there in the Charaka Samhita and book, what are the diets related for it. And if anybody can help that, we can coordinate with the swims and other things, because we have both Allopathic Institute and Ayurvedic Institute and the Central Institute, where we want to have a diet plan for each part of the country, sir, because the traditional Indian foods, what we have, definitely has the impact on the glycemic load and the glycemic variability. So in our practice, what we are observing is, because many of us, we see the poor patients of our country, they tell that we'll take the, in Telugu we call sadhyanam, that is a overnight remaining food with water or buttermilk they will take. So when we see that the PP values, sometimes they are really good, like coming around less than 200. I request you, because you are in the apex body, we can target the poor people of the country, rural Indians, where with our traditional Indian diets, which have been followed for the past 40 years ago, if we can incorporate in the studies, and some centers have been selected pan-India, definitely we can be useful to the society, sir.
I totally agree with you there, ma'am. I think this is right in the beginning of lecture. I said, this is something needs more research. Diet, drugs. Western pharmaceutical companies have done the research. We are only cutting and pasting it and putting it on the slide. We have not done much, but diet we can do, because Western people don't take our type of diet. There will be differences between North and South diet, and there will be definitely
indigenous foods which are beneficial, including millet. This is the year of the millet. Millets is something which needs more research, and I'm glad that Government of India are doing something about it.
What would be interesting is to add a transcriptome arm to this, because be interesting to see whether the inflammatory proteins are overexpressed or underexpressed, but not from a serum marker, but a transcriptome marker would probably also be very useful. Yeah. Dr. Das?
Yeah. Anup,
Anti-inflammatory markers you're asking?
No, the marker, no, but the transcriptomes, not the markers, yes.
Anup, I am here to have two things, one apology, one appreciation. The apology because that your paper which came was not quoted in the pre-diabetes paper, because I think the earlier paper we have quoted, but not this paper which came now. So I have been asked to write a letter to editor. So I'll be including the thing you have said, which are absolutely fabulous things of a protein 30 minutes before, consisting of inexpensive protein or even the protein which can really make a change in the pre-diabetes. The second appreciation comes from you and one of my friend called Dr. Babaskar, you know him, who got Padam Shri for the snake bite and the scorpion sting. He was in API last week. He gave his talk in 5 minutes. He said his original research, I don't need more time. You rightly said that it has been plagued, and you said no more studies, and it has given proof of the pudding. Thank you.
The evidence, I'm glad that you got funding from Alman. So gastric empty could be done by MRI. Insulin secretion, you are in an institute. Let us put it, scientific evidence-based one, so that then in the conferences, at least speakers can have element. We people, we can have poor groundnuts. The question is whether groundnuts, of course you got funding, but you can also groundnuts. You speakers, you have, because I don't know what do they provide the speakers, they don't allow us.
That was actually my next question. Can groundnuts be substituted in India?
What about Congress Karle, right?
No, I mean, same thing we tried. I mean, that's a very valid question he has asked. Groundnuts for poor people, because it's available and cheap.
Both of you are absolutely correct. And there is a huge review on the nuts, tree nuts, and including groundnut. What is the peculiarity of these nuts? Why are they more beneficial, including groundnut? Is because of high monounsaturated fatty acid. Almost unequally, every nut has a high, some more, some less. This has a very high MUFA. Now, as far as peanuts are concerned, I think Dr. Mohan did a study previously and shown result. So clearly you have a point, but I don't have a research at the moment, sir.
You could, because CDM at the moment is devastating. All these things which you put, not here, in colleges and schools. This is, trial, somebody should go to the society. Otherwise, you will be bankrupting the country, thanks to your all debate or no.
So, I mean, Dr. Mohan was alluding to this yesterday in his oration. So, thank you, Dr. Mishra. Thank you, everyone, for a great conference. Can I have Arvind do the last words of the conference? Thank everyone. No. Come.
Thank you so very much, Krishna. I think you have wonderfully organized debate in Chennai, and this is the 4th or the 5th time that you are doing debate in Chennai. We as a group from Primer, it's a set of doctors who decided that we must have a conference to give a common platform to all the pharma companies, and wanted to bring in a lot of basic science. It was difficult to start with, but then we have been able to maintain it. I would like to thank your team in Chennai, which has really worked. Would love to thank all the doctors, all the speakers, all the faculty, the hotel people, the pharma people who have come. And most interesting thing, you don't get, I know the doctors who have been there, as this one, I thank them.
Can a good applause for Dr. Balaji Chidambaram, Dr. Rajesh, Dr. Gauri Shankar, Dr. Kannan, then Deepa and everyone else in this.
Yes.
And thanks to our great faculty.
While it takes a lot of effort on part of a speaker to prepare and come and speak, it also takes a lot of patience and a lot of time even for the people to come and listen to the lecture. So I would really like to thank the delegates. And the program started as early as 9 o'clock, and at least in Bangalore, I don't see so many people coming at 9 o'clock. But in Chennai, all the 3 halls had more than 150 to 200 people in all the 3 halls.
At 9 a.m. and that's the Chennai spirit.
And we had over 1,200 delegates who had registered. Few also came just before the lunch today and then we had to say no because.
So we had 2,000 registrations, of which about 1,400 people have come on the last 2 days. And amazing science, thanks faculty, thanks everybody. And you know, that's the spirit of debate. Now it's time to have good lunch. And one thing about debate, one, we showcase our culture. I don't like silk, but my wife insisted I wear silk, but I like a cotton dhoti. Please encourage handlooms here, all our shirts. I think it's very important. Second, the food is curated. So you won't find, sir, no paneer. So we will find today good Telugu food. Please enjoy, and we will see next year, first weekend of February, back again. Thank you.
Thank you so very much.